your hand on Teams and we will react. This end, please, if you could mute it again. Thank you very much.
Well, thank you very much, and welcome to Brentford Football Club, which is the venue for our latest North West London Acute Provider Collaborative Board in Common. As an Everton supporter, I think bringing me to a football ground the day after we got beaten 6-0, I think probably contravenes a number of the NHS's bullying policies, and I will be taking that up later. But I'm doing my best to be brave. But welcome to members of the public who have joined us. And welcome to our board members, executive and non-executive. Just to note that we will be recording this meeting. So by joining us in the meeting, you are giving us permission to record it. And that at the end of the meeting, we will take questions from the public. We have, I think, one question has been submitted in writing, which we will take first, and then, if we have time, we will take other questions from the public. Peter, something unpleasant happened to the last meeting's recording.
Yeah, thanks, Matthew. Having said that we record these meetings and we publish them on our website, you'll remember the technical issues that we had at the last board meeting. It made the recording unusable in terms of a public accessibility recording, so we haven't published it. It does exist, but it's just not good quality, in case people wanted to know where it was. And just to add to the second apology, already I'm only 2 minutes in, is the questions and the answers from the last board meeting. They are published on our website. There was a delay in doing that. So for those members of the public who ask questions, who are searching for them, then apologies, but they do exist now, and we will get better at publishing those in a timely way.
Thank you, Peter. So those of you who remember our last board meeting, remember that if you were in the room, you froze to death, and if you weren't in the room, you could only hear one word in 5. So I think we're doing better this time. Firstly, apologies for absence. I've got apologies from Sim Scavatza and Nina Modi, and we are being joined online by a number of our non-executive directors, Martin, Neville, Carolyn, Saeed. Do we have Vinita joining us? Vinita Manchanda? I think she has. In which case, welcome. I can see you there now, Vinita. Welcome. So Vinita will be joining us as a new NED from the 1st of May. So she's joining us to observe this. You're very welcome. Oh, and we got Baljet online as well. Thank you. Moving on, declarations of interest. Peter is going to present the declaration of interest paper. Do you want to give us?
Thanks, Matthew. Thanks, Matthew. So this is the annual presentation of the register of interests for all 4 trust boards meeting today. You'll obviously recognise that we do interim updates to the register as we go through, and at each meeting people are invited to provide their comments. But this is for the public record, just 2 minor amendments to the paper that is published. I think recognising that Claire Hook's entry should actually read Director of Hook Medico Legal Limited rather than Chartered Director. And Loy's interest in the Digital Health Council is a non-financial personal interest rather than financial.
Thank you. Has anybody got any other matters of interest that they need to, declaration of interest that they need to raise at the beginning of this meeting? Very good. Thank you very much indeed. Moving on to the, so we now need to, we will note that register and it will be published on the website for people to be able to see. Okay, so minutes of the previous meeting. Could I just draw your attention to one typo, which is in number 4.2, where we refer to Oliver Gowan. That should refer to Oliver McGowan, which is the Training on Learning Disability and Autism programme. Are there any other corrections that we need to know about?
Not received any.
Okay, thank you. So we will, people happy that they are a true and accurate record? Good, thank you very much. We will accept those as, as a record then. And I've not been notified of any matters arising. Are there any matters that people need to raise out of the previous minutes? No, good, thank you very much. Okay, in which case I'm going to move on to our patient story, where we are being joined by Gemma Marshall, who's a patient who's going to share with us her experience of the ENT pathway. Patricia, do you want to do an introduction?
Yes, so if I can introduce Gemma, who's joined us on Teams. Gemma is actually a radiographer at Hillingdon Hospital, so she can give us some real insights as a deliverer of service and a user of service of her experience on an ENT pathway. And I'm going to hand over to Gemma to take us through her story.
Thank you, Patricia. I hope you can all hear me okay. Lovely.
We can hear you perfectly, thank you.
Fantastic. Okay, so after about 5 years of increasing nasal congestion and getting fed up with colleagues and people on the telephone asking me consistently if I had a cold or how was I feeling all right, I finally took the plunge and decided that maybe it was time I went and saw somebody from ENT to work out what was going on with this nasal congestion I'd had gradually. As I'm sure many NHS staff will be aware, that with COVID and everything else, we sort of put our own health necessarily on the back burner and didn't always put ourselves first. So I was recommended an ENT consultant who works at both Hillingdon and at London North West, Mr. Majithia, by colleagues, and decided that through patient choice and for convenience with work and having to take less time off work, I would like to be referred to see him. So I spoke to my GP. The referral is not straightforward, as I'm sure many people will appreciate and understand. I don't actually live in the catchment for Hillingdon Hospital. I live in Hertfordshire, and therefore my GP had to refer via the community ENT service in Hertfordshire. And I was told that that's fine. They could make a note of my patient choice on the referral, and that community triage system would then refer me back to Hillingdon, which it didn't. I was then offered an immediate referral to the community service at Harpenden, over an hour away from home, not overly convenient, at 8:15 in the morning for then trying to get to work, and would mean I'd have to take at least half a day off work, which obviously wasn't particularly convenient. With my knowledge and with my access to NHS email, I managed to get in touch with one of my GP practice partners, explained my disappointment at not being able to use patient choice, and that I wanted to be seen by this particular service at Hillingdon, and for the reasons I wanted to see this. And he kindly did a direct referral by letter to ENT at Hillingdon, and I was accepted onto the pathway. So apart from that minor hiccup at the beginning, everything had actually been really well. So I was referred in September last year. I saw Mr. Majithia in clinic at Hillingdon very efficiently. Everything was running on time. He was charming, professional, very friendly, gave me a very thorough examination right from the start, including a nasal bronchoscopy during my outpatient appointment, to which he discovered I was indeed extremely congested, and also found I had a right-sided polyp, which was going to require endoscopic surgery. And also I got a telling off for leaving it so long, and why had I left it quite so long before coming to see anybody. So I went away with my tail between my legs and decided that he told me I would have a CT scan of my sinuses, some allergy testing, and he would also refer me to Harefield Hospital Respiratory Medicine for a sleep study, as I was at high risk of sleep apnea. So working at Hillingdon, I was able to arrange the CT scan very efficiently, as it's the service I'm in charge of. So I managed to get that very quickly, although to be fair, I waited no longer than most of our routine outpatients would wait. So we have a very quick turnaround for these type of scans anyway. So there was no preferential examination on that, other than the fact I was physically in the building and could be scanned when I needed to be, rather than having to come in on an appointment. I had my scan on the 9th of October. A week later, I then caught COVID for the first time and was actually off work for 3 weeks. It completely floored me, during which time I was actually offered a surgery date of the 13th of November, which I had to decline because of my COVID. Once I'd recovered, I was then able to have my allergy appointments, which had been postponed. They were carried out on the 3rd of November with the specialist nurse here at Hillingdon, and she was absolutely amazing. She went through everything that I needed to know. I didn't really know what that was going to involve. Never had any allergy testing before, but she explained everything right from the start, and talked me through everything right from the beginning. It was really good. And I was actually really surprised that everything came out negative. I have to say, I completely assumed that a lot of my congestion was allergy related, and that it was sort of hay fever or dust from work or the aircon units or anything like that. As I work with, big electrical pieces of equipment, we've got dust everywhere. I thought maybe I was just having a normal rhinosinusitis. So I was quite surprised when actually everything for normal variants came up negative. So that was very good. And then I was referred for surgery again. And this time, obviously, I was then referred. We don't do surgery here at Hillingdon. So I was referred to London North West, and I had my pre-operative assessment at Central Middlesex, which was a bit of a blast from the past for me because it was where I'd worked when I first graduated in 1998. So it was going back to my old stomping ground. Looks completely nothing like my old stomping ground because Central Middlesex has been demolished and rebuilt. I am proud to say I actually was a member of staff that was at ACAD when the ACAD building opened by Tony Blair. So that was quite reassuring to go back and see that building look very little difference, to be fair, just different departments in different parts of the building, and the coffee shop not being at reception where it was when I was there before. So yeah, that was a bit strange going back there, but they were so lovely, very efficient. There was signposting was easy, it was easy to find. The nurses were exceptional, they were very friendly, explained everything they were going to do. I had standard bloods and other clinical observations done, height and weight, and I was advised that I would get a follow-up phone call to go through any details, and that did indeed happen on the 1st of December. Again, the nurse on the phone was very friendly. She introduced herself, explained what was going to happen, offered me the opportunity to ask any questions. So very, very happy with the pre-operative service. It was very thorough and clear. I then had a follow-up appointment with Mr. Majitha on the 13th of December, actually at Mount Vernon, and he went through all my test results. We looked at my scan, we discussed my surgery, and I then was offered, told I would hear from a surgery date as soon as possible, and that it was likely to take place at Central Middlesex. They were also looking at referring me to Harefield properly for my sleep study to be arranged after my surgery. Now, in November, we went live with Cerner, and Guy's and St Thomas's Hospital Trust, which Harefield is now part of, went live with their Epic not long before. And quite interestingly, when I was finally contacted by Harefield, there was a bit of confusion in my details. So it actually came addressed to my maiden name, but with my married title. I have been divorced since 2015 and have never lived at my current address under my maiden name or using my married title. And yet my letter from Harefield came addressed to Mrs. Gemma Tyrrell, which was quite interesting. And it appears that it's a communication between Cerner and Epic that caused that to fail. And I'm aware that I'm not the only patient that this has happened to. So I think that's something we need to be aware of, lots of different trusts working together, but different IT systems. So it was rectified by the respiratory medicine department there very quickly, and they got it all resolved. But I was definitely told it was a Epic versus Cerner clash that had caused that. So I'm sure there were other patients affected by that as well. And maybe letters didn't go to the right place or whatever. It did come to the right address, just addressed to the wrong person or slightly wrong person, which is interesting. On the day of my surgery, which was the 5th of February, I was taken into the ACAD building at Central Middlesex, and it was really well organised. We all sat down, they came down and escorted us up to pre-op. Everybody was taken in, there was loads of staff, so there was lots of us going in for different types of surgery surgery, but there was so many staff available to help. Everyone had a one-to-one member of staff take them through to their cubicle. The arrival, check-in and pre-surgery daycare was so well organised, very efficient, very friendly, and everyone was very helpful and clear in their instructions. It became really busy, as it would do first thing in the morning, but everyone from the anaesthetist, the nurses, the surgeon, everyone took time with me. I didn't feel I was rushed making decisions or signing my consent. I felt that they explained everything thoroughly. There was no sense that they were waiting to get on to the next patient. It was quite thorough. And I was lucky to be first on the list to theatres, so I swiftly disappeared down once I'd got changed down to theatre. Everyone in the theatre introduced themselves, as they should, and I was really impressed that everybody actually came up to see me and told me who they were and what they were going to do, what part they had to play, and that was brilliant before I was put to sleep. I don't recall much of my time in recovery, although the people I do vaguely remember speaking to were very nice and were explained to me what was going on, but obviously I was a bit still groggy from the anaesthetic. But once I got back to main daycare, the staff there were really caring, really reflective, really friendly, happy to help me out, and got me discharged back to the care of my dad, who kindly assisted me in that occasion. So I was called by the daycare team the following day to check how I was doing, made sure that I was following my instructions properly, that I'd got all my medication, and that everything was okay, and did I have any further questions. I then had a sleep study arranged for the 7th of March, which went ahead, and I have my follow-up for that actually tomorrow, so I shall have a video call with them tomorrow for that. I had to chase up my post-surgical outpatient appointment with ENT. I didn't receive an automatic outpatient. It says 6 weeks afterwards. I waited and waited and nothing came through. So I did have to chase that myself. So again, luckily I had connections and was able to email the registrar and find out what was going on with that. But and it was fixed very quickly. But yeah, that didn't come through to me automatically, which obviously it should have done. But I've now been discharged from the service, and I feel much improved in myself. I mean, overall, apart from the frustrations of the initial referral, I found everything very efficient. The communication between both sites has been brilliant. Other than the IT issues between here and Harefield, the communication there and the transfer of my information and my notes and what was going on has been very clear. And I think it's really hard, actually, being a staff member, putting yourself in the hands of another team. It's very hard to be on the other side of that, but they made me feel completely at ease, and I trusted every single member to do their job properly. There was never a point where I felt I had to question something, or I would have to ask somebody with my bit of knowledge. I think knowledge is a dangerous thing, to be honest, at times, but I let myself be in their hands and only really used my knowledge as a member of staff to support that. But I tried very much hard to just be a patient and let them treat me as such. But I can't fault the service and the care that I've actually had across all the sites. I said they were absolutely excellent, and it was lovely to go back to Central Middlesex and see how it's changed and progressed and modified in those years that I've not been there. So thank you very much.
Thank you, Gemma. Thank you for sharing your story. Pleased to see that when we do our staff surveys, we always ask the question, would you be prepared for yourself or a member of your family to be treated in your hospital? And you would answer yes to that question because you did so. So I'm pleased about that. I think your point about patient choice at the beginning is a really important, because patient choice does exist as a right for patients. It's still in the NHS constitution, but it's increasingly hard for patients to access, and you shouldn't have to do what you did in order to be able to express a way onto. And I think that's something for the NHS more widely to think about what's happened there. Any questions or comments that anyone would like to add? Steve and then Patricia.
So Gemma, thank you. Is there anything that, from your experience, other than the piece at the beginning and the IT, that as part of the normal procedure that you think we could do better?
No, I actually think it was very well organised. I think the information given out was quite clear. There was continual text messaging about appointments, and So I didn't get to miss any appointments because I got text message reminders. I suppose the only thing we have to consider there is that we do have a population where not everybody has a mobile phone or access to that. And so have we got fail safes in place to catch those members of those patient cohort that aren't as tech savvy as the rest of us? Because there are things like, my follow-up appointment at Harefield tomorrow is a video call and it's through my chart. And so unless you've got a mobile app or something like that, I don't know quite how not every patient might feel comfortable having that kind of conversation or that kind of follow-up. But I think actually from my perspective, it was excellent. It was just so straightforward. It was probably one of the most straightforward things I've had to do in the last few years. And I've had a fair number of various hospital appointments and bits and pieces in the last few years for orthopedics and other things. So it just was very straightforward and very, very clear all the way through, to be fair.
Thank you. Thanks for that. Tricia.
So I wanted to make an observation more than a question for Gemma, but I think it's a really important point you make, Matthew, about patient choice. And actually, we need to understand that patient choice nowadays is not necessarily about choice at another hospital. It's choice in a community setting. And I think it's an important point that, Gemma, you had a very clear view. You wanted to see a particular clinician at a particular site. But actually in Hertfordshire, the option was to go to a community clinic, possibly, and I don't know, possibly with a private provider or whatever. And I think there's probably something for us about how do we make the public more aware of the different options that are being made available when they may have a very clear view about what they think patient choice means.
Thank you. Thank you. Pat.
Mine was an actual observation, Gemma, because it seemed that you were treated pretty quickly. And so there would go back to Patricia and Pippa to ask if that's unusual, because I thought ENT was one of the places where we had longer waiting lists. And what were you from start to your first appointment, Gemma?
So I was referred in August and I had an appointment in September, but I do believe that was a cancellation appointment, to be fair.
Oh, yeah. So just thanks. I mean, that does seem really speedy. And I think the public would think that. So how normal is that, or what's the normal ENT list?
So I think it depends per procedure. So we have got longer waiting lists. ENT, particularly at London North West, we've got a huge cohort of ENT patients. We're a big ENT speciality, and it's one of our biggest waiting lists. That doesn't mean to say all them patients are waiting that long. It depends on procedure, and actually for this procedure, that's not a long waiting time to have that done.
Great, thank you. Thank you very much. Well, can I thank you for giving up your time to us here, Gemma? Also, I think we've got Catherine Holly, who's the head of patient engagement. So thanks for making this happen for us. And I'm not sure if Pardeep Gruel has joined us as well, but also she as the service manager for ophthalmology ENT. Oh, and we've lost our screen. Oh, I think you can all see us. We just can't see you, so that's okay. So thanks for everybody who'd made it possible for Gemma to join us and share her experience with us as well. So that's great, and I'm pleased that it went well and that you're feeling well. So thank you.
Thank you.
Okay, I'm going to move us on to Chair's report, my report, which is in the papers. There's just a couple of things that I wanted to pull out of it. First of all, let me start on behalf of the board by thanking Neville Manuel, who is joining us for his last appearance at our board today. Neville's been a board member at Hillingdon for the past 3 years and Chelsea and Westminster since September 2022, and has contributed an enormous amount to the trust in committees and activity, and will be sadly missed. So Neville, running away to Spain, I think. So, but we will. There's a degree of wave of jealousy is going around the board. But thank you so much for everything you've done. It's been an absolute joy. I'm also like take a chance to welcome lawyer Lobo, who has officially joined the board in common as a non-executive at London North West and Imperial. Loy, it's great to have you here. It's been great to have you on your first few committee meetings over the last couple of months as well. It's great to have you on board. And as I mentioned earlier, we also have Vinita Manchanda, who will be joining from the 1st of May our acute collaborative board at Hillingdon Hospital and Chelsea and Westminster, and it's thank you for joining us to see what goes on here, and we're looking forward to having you as part of the gang. So thank you very much, and you're very welcome. And David, I think this is your first meeting as the new vice chair at London North West as well. It's going well so far, so keep it. So it's great. Constant, when you have a board as large as this, there is a constant turnover of people coming to the end of terms and new people joining and keeping us refreshed and on our toes. So we're just at the beginning of a new financial year, so I think worth just taking half a moment to look back on some of the things that we have achieved in the collaborative. Pleased that we have seen our A&E performance improve during the year, and by the end of the year was amongst the best in the capital, and that our elective activity across the collaborative is up to around where we were pre-COVID, which is something the NHS is struggling with, and as I'm sure will be pointed out to us again later, we continue to deliver some of the safest care across our wards as well. So thank you to the leadership here and to the staff for everything that they achieved last year. I do think in difficult circumstances we are making real progress, and people are doing tremendous work for the local community. We have opened 2 community diagnostic centres in the past year, and we have, as well as a major refurbishment at the Western High Hospital, and we have a number of capital programmes running into the coming year, which will continue to see improvements of our facilities. And the last thing I just wanted to mention was we got our staff survey results back, and whilst there are learnings and things to take out of that, and we are a long way from perfect, we have seen all of our trusts has seen improvement in our staff satisfaction surveys across the board, and I think that is a sign of both the commitment of the staff and the efforts of the leadership. So my thanks for that. I'm going to take us on now to the board in common cabinet note, which is in the papers, and I think I just need to draw your attention to the fact that at the cabinet we signed off 3 business cases. Part of the role of the cabinet is to deal with things that come up, so in between board meetings. So we signed off the outline business case for the Chelsea and Westminster Ambulatory Diagnostic Centres equipping. We signed off the contract award for food supply at Imperial College Hospital, and we signed off the contract for the lease of the Energy Generation Centre for Hillingdon Hospital. So I just bring those to this board for noting. And then I'm going to move us on to our Integrated Quality and Performance Report and turn. Leslie, do you want to introduce it? Otherwise, I shall work our way through, starting with Patricia.
So thank you very much. So I'm going to hand over to Claire, actually, who's going to coordinate all of this. But I wanted just to echo a couple of things that you've said, Matthew, which is a lot of hard work's gone in during some very challenging times. And we'll hear from our colleagues just about what they've managed to achieve, and still some work that we've got to do. And at the end of it, actually, Simon rightly reminded me about, which I've got 2 Simons on either side, so, but anyway, that we need to do something about discharge. We've started to report discharge in here, and I will talk about discharge and take some questions on that, but I'm going to hand over to Claire, who will coordinate all of this. Thank you.
Claire, do you want to introduce yourself just because people can't read that sign from a distance?
Of course, thanks. Afternoon, everyone. I'm Claire Hook. I'm the Chief Operating Officer and Deputy Chief Exec at Imperial. So the plan is I will talk us through our UEC performance. The report includes data up until February, but we should be able to give you a flavour of the year-end position now, given where we are. I'm then going to hand over to James, who'll talk us through cancer, technology permitting, Tina, who'll do electives and diagnostics, and we've also got Sheena from Chelsea who'll help us with any questions as we go before I hand back to Leslie. But just before I get started, I want to just echo a couple of things that Leslie said in terms of putting our performance in context. So we measure ourselves in this report against the standards that NHS England set for us in the operating plan guidance. And also we benchmark ourselves generally against other trusts in London and more widely. And if you look at those two measures across all of the key operational performance metrics, we are doing well. And that is testament to the hard work and effort and enthusiasm of everybody over the last year to get us where we need to be. However, if you think about that performance in the context of the constitutional standards, we are still a long way from where we would want to be and a long way from delivering the access for our patients that we would want to. So all of the hard work and effort that's gone in over the last year will be doubled again as we go into this year to make sure that we continue to improve. But just turning to urgent and emergency care performance, you'll remember over the course of the year, we've had a plan in place to get us to 76% of our patients who attend the emergency departments treated within 4 hours by the end of March. In 3 of our trusts, we managed to achieve that in February, and we did it in all 4 of them for the month of March, which was a huge result. And we did that whilst also increasing our ambulance improving our ambulance handover times rather, and decreasing our very long waits in the emergency department. So our efforts now are focused on continuing the action plans that we've got and making sure that we can sustain that performance. And over the course of the next few weeks, we're going to regroup to look at what the improvement plan is for the coming year. Excellent performance noted. There are just 2 things that I wanted to flag to the board in relation to where we are at the moment. And that is, first of all, in order to accommodate the demand that we've got coming through our front door, we still have all of our capacity open that's been open over the winter period, and we need to work out how we're going to deal with that going forward. And the second thing is, as Leslie I expect will touch on in a few minutes, we've had lots of support from our borough and local authority partners and other partners across the ICB that we need to continue as we go into this year in order to keep the improvement going. So with that, I think I'm handing next over to James to talk about cancer.
Thanks, Claire. Good afternoon, everyone. I'm James Walters, the Chief Operating Officer at London North West. Our cancer performance in North West London overall remains comparably good against London and national performance levels. The January performance, because cancer data is generally reported a month behind other performance standards, shown here, was impacted by both industrial action and probably most notably the high demand for urgent and emergency care that we saw during the early part of January particularly, which can challenge that balance between the urgency of cancer outpatients and diagnostics and the urgency of high levels of emergency care demand heading for our A&E departments. It's worthy of note that both London North West and the Hillingdon Hospital continue to recover and make good progress on their Cerner Go Live stabilisation. Performance is gradually improving despite the challenges set out in January. To give you some examples of that aren't shown in the pack, I'll briefly refer to where we've moved to in February, as we've now got the data, but it wasn't available at the time the papers were published. On 2-week wait, London North West has moved from 62% to 73%, and Hillingdon Hospital has moved from 67% to 81%, so good additional recovery there. In terms of the faster diagnostic standard, London North West has moved from 68% to a compliant position, above 75%, and pleased to report that the Hillingdon Hospital has also moved to full compliance with the faster diagnostic standard in February as well. The 62-day pathway. Both trusts and all trusts, in fact, in the sector delivered against their backlog improvement. So the clearance of patients waiting over 62-day remains in good grip across the sector, and we delivered a compliant trajectory. The performance standard is set out in a percentage in the 62-day pathway, and that still is our main focus area of challenge. But as we clear the backlog, obviously we stand more of a chance of delivering an improved percentage. I would say that we're all very competitive. We can see that we're nearing the London level of performance on some cancer domains, and we very much wish to stay above and compete in North West London to deliver excellent care for our patients. Thanks, Claire.
Thanks, James. Tina, are you doing electives and diagnostics?
I will do, thank you. I'm Tina Bankson, the Chief Operating Officer at Hillingdon, and similarly to Claire's statement, I think we need to remember that whilst we're doing extremely well, both in London and nationally, we are obviously a way off the referral to treatment waits being 18 weeks. So I think we just need to recognise that in our ambitions for the coming year. However, all trusts continue to improve their long waiting patients. So 78 weeks, Hillingdon delivered no 78 weeks at the end of March, and all three other trusts are down below, just validating some of the breaches, but should be down below 50 each according to the latest data. And those patients obviously will be worked on, and all trusts are committing to clear all of their 78-week waits by the end of June. And we're monitoring those very closely through the weekly meetings with the DDO colleagues and through the elective care board on a weekly basis. And we continue to work on downward trajectories for both 65 weeks and 52-week waits. You'll see in the pack the challenge specialties are trauma and orthopaedics at Chelsea and Westminster, ENT, ICHT, and you were right, Pat, ENT at THH. And gynaecology across London North West, and all of those we provide mutual aid where appropriate for our patients in North West London. So we know that industrial action, as James said, has had an impact, and looking at the data from the trusts, this ranges from between 2% and 7%. The lower percentages across all organisations seem to be outpatients, so that 2% range is the number of additional, we could have done 2% more outpatients had industrial action not happened. And then the bigger impact on the cancer pathways, as James said, is the inpatient day cases. Across all four organisations, the impact is about 7%. So that's the scale of the lost opportunity through industrial action. So what are we saying when we say that? Well, we've done really, really well to hit the position we have. We could have been better had we not had to manage industrial action because we had high levels of cancellations. In terms of diagnostics, we have seen a deterioration overall in the position, and all trusts are looking to recover DMO1 by the end of Q2, but there are subspecialties within that that currently trusts are saying are going to take longer to deliver, some up until March 2025. So we're meeting with particularly ICHT and Hillingdon to look at what mutual aid or insourcing we can put in place with each other to bring all of the specialties back in line with an earlier trajectory to deliver each specialty to the DMO1 level of 95% of national OFS for next year. Thank you, Claire.
So thank you. I'm not sure I can make, oh, I am making it work. So I think, so you've heard about the performance. I think you will also see that we have a good look at productivity through theatre utilisation, outpatients, so need to follow up, and indeed PIFU, and our bed occupancy, which leads me very nicely on to the discussion that says part of that productivity involves not just ourselves in terms of length of stay and our productivity around discharge of zero-length P0 patients, so patients who can be discharged with an uncomplicated out-of-hospital pathway. But we have continued to have some challenges, although there have been some improvements in the discharge of patients who need some ongoing care, and they are the subject of discussions practically daily between ourselves, the community unit, our mental health unit, and indeed our local authorities. We've had some very particular issues more recently around equipment, which we're working on with our colleagues out of hospital. But you'll be able to see the improvement, I hope, in length of stay and the associated occupancy levels as we work together with the place-based partnerships to discharge patients as efficiently as possible. But happy to take any questions on all of that before we hand over to Pippa.
Yes, so let's take any questions or comments that people want to make on the operational performance. Any questions? Nope. Very good. Okay, thank you very much. In which case I'm going to go. Sorry, Nick, I missed you. My apologies.
I suppose my general question was that there's clearly been a push, which has been partly finance related in year end, certainly Hillingdon in terms of A&E performance, that has really driven an improvement. And I know that's across the piece because there has been a real imperative. I suppose my question is, how confident are we that those changes that we've made to improve performance are embedded and will be continued to deliver as we go into a new financial year?
So I think that's a very fair question. Very fair question. So I think that's part of, and actually one of the benefits of the collaborative with Eremoni, is that learning from each other about the pathways that we use and the cultural approach that we use as well. So you're right, there was a real push for the end of year because of there were some incentives to getting that level of performance in terms of capital. But I think we will be looking to sustain that performance, and I think we will be having a very hard look if we can't do that. So I think still more work to be done because we haven't proven that it is sustainable, but we're pretty determined that it should be.
Thanks, Leslie. Any other questions? Thank you. In which case I'm going to come over to Pippa. Do you want to take us through the quality stuff?
Thank you. I'm just going to start and then I'm going to hand over to Alan for quality and then Robert for maternity. What I would just say as a starter is we're just going through the process of reviewing these metrics. So we start the new financial year on a fresh set of metrics that reflect the national agenda in terms of some of the quality initiatives, such as the initiation of PSERV, some of the new national maternity objectives. So you will see a change in the next integrated board report in terms of the updated metrics. But I'll hand over to Alan for the safety and then over to Robert after that.
Thank you, Pippa. Thank you, Chair. Yes, what to say, the performance is similar to previous months.
Alan, can you introduce yourself just because people who are joining us?
I do beg your pardon, yeah. Dr. Alan McGlennon, Chief Medical Officer for Hillingdon. Yes, performance is similar to previous months, hitting most of our metrics. I'll draw out a couple of salient points. Some positives, which is that the mortality remains some of the lowest in the country. Our PSERV transition is on track in all areas of the APC. We do have some NIVER events that we've got to record. We had 2 in this month, which makes a total of 11 for the year. What I would say about that is if you analyse them, mostly they are procedural, and therefore the LOCSIP work that is part of our quality priority for 24-25 does deal mostly with them. IPC has been an issue and remains to be, which is infection control, beg your pardon. All trusts are still reporting above the national thresholds. It's an APC priority workstream, and again, this is something that we have to work with collaboratively with the ICS, as many of the metrics. The patients are arriving with nascent infection that we don't know about, so working together will be the answer for those areas. More about the procedural aspect of safety. Our LFPSE is replacing the NRLS in our DATEX system. What is that? That's really about how we log our incidents, how we rate them, and how we communicate them with ourselves. And that's live in all parts of the APC. We have done a review of our SIs, that's our serious incidents, and they are consistent with our plans going forward, our patient safety plans, and therefore clearly they align with our quality priorities. As I said, LOCSIP's been the main one. I'll stop there because there's a lot to talk about with maternity and maybe come back to me from that.
Thank you. Can I open this up for any questions to Alan, Pippa, David?
Great. Thank you, Alan. Can I just check, how are we sharing health and safety learnings amongst the 4 trusts?
Yeah, go. Try again.
It's a good question, David. Luckily, I'm forearmed that this is your specialist area of interest. It's a good challenge. We've just taken an annual report to the APC Quality Committee that brings together the 4 health and safety reports from all 4 trusts as to one report that reported last month to the Quality Committee. It did identify some differences between trusts. Now, that might be fine in terms of how we report it and what committees we report it to. But what we have agreed to do, which I think Dawn is leading for us across the 4 trusts, is just to standardise how we do reporting, how we do learning, how we share learning, and how we report to committees. So we will be doing that work over the next few months.
That's because we were hogging the microphones here. But, thank you. Any other questions or? Dawn, you wanted to add something?
I just wanted to add that in addition to Pippa's contribution there, the health and safety teams across the 4 organisations have now established a working relationship together. So they are meeting every quarter so that they can share learning between themselves. I think that then poses the question about how does that learning then get disaggregated across the organisations, and we'll take that away.
Thank you. Did you want to add something, Patricia?
Yeah, it was on a different point, really. I think one of the other things that we should observe as a board, if you look at the Friends and Family Test, which is a less than perfect measure of patient experience, but is the measure that is used across the NHS, that given that we all saw dips in emergency performance over the sort of latter part of last year, we're actually seeing patient experience picking up again quite positively. And I think it's quite interesting to see as we've improved our performance, our patient experience is improving. And I think that's very important, actually, because it is the front door, it is the mirror of the hospital, and it's good to see that change.
Thanks, Patricia. Can I come to you then, Rob, to talk about maternity?
Yeah, thank you. So Rob Leesdale, Chief Nurse at Chelsea and Westminster. As Pippa referenced, we're currently doing a review of our maternity metrics in line with the national requirements, but also to make sure we capture our equity and inclusion agenda throughout the maternity pathway. So to call out a couple of points within the report for maternity, you will note that in month of December and January, we've seen an increase over the last 2 months in our stillbirth rate across the acute provider collaborative, with 14 cases, unfortunately, in the month of January. Looking at February, this has reduced down to 6 cases across the collaborative, with 2 at Chelsea, 2 at the Hillingdon and 2 at Imperial. And whilst it's important that we recognise that increase in month, if we look at the year-to-date crude stillbirth rate, 3 of the 4 trusts are below the national target of 3.3, with the Hillingdon exceeding that threshold, and the Hillingdon haven't completed a stillbirth review as referenced in the paper. Each stillbirth undergoes a review using the perinatal mortality review tool, which is a multidisciplinary tool, and we are working with the LMNS to review that regularly through the LMNS and the Acute Provider Collaborative Quality Committee, and we'll be strengthening that as part of our maternity work stream as the year ahead and reporting that through here. In terms of suspected neonatal intrapartum brain injuries, we've had 1 case where a baby was transferred to Queen Charlotte's for cooling, and subsequent MRI was normal and in line with the, I need to remember what the new title is, it's MN, Maternity and Newborn Safety Investigations Team, that has been referred and is being investigated currently, formerly HSIB. In terms of babies born in the appropriate care setting for gestation, just to remind board members and members of the public, this is where either a single baby less than 27 weeks or 800 grams or multiple babies less than 28 weeks, they should be born in a facility where they have a level 3 neonatal intensive care unit. For the acute provider collaborative, that is the Chelsea site and Queen Charlotte's. you will see in month there has been unfortunately 2 cases where babies were born in inappropriate care settings, and that being the West Middlesex site at Chelsea, where the lady presented actively in labour and wasn't able to be transferred in time to Chelsea, and then one at the Hillingdon where the mother was also unstable for transfer. As part of the work across London, there is a Pan-London inter-uterine transfer guidance, and we're strengthening the Pan-London escalation policy for transfer of women between units to make sure that we have capacity to do that safely. I think I'll stop there.
Thank you. Any questions or comments? Pippa, did you want to add anything? Steve, you trying to come in? Okay, thank you very much, Rob. Okay, so come back to you, Pippa, for workforce.
Thank you. I'm going to hand over to Tracy shortly just to talk about, I think it's the first time you've seen our workforce res indicators in this, so Tracy's going to talk through that. But in terms of the high level people priorities, really moving in the right direction. So it's the first time we've had all 4 trusts now achieving a vacancy rate less than 10% and a turnover rate lower than expected to, with complete compliance across the 4 trusts on Statman training. Our further areas to work at, which we've identified before, is the non-medical appraisals, which are slowly creeping up, but slowly, and we're still aiming to achieve, bar Imperial that have already achieved a 90% compliance. The other 3 are chasing behind to achieve that. And I'll let Tracy talk through our equality indicators in the workforce paper.
Tracy.
So the model employer goal.
Tracy, introduce yourself, please, so people know who you are.
Hello, I'm Tracy Connage. I'm the Chief People Officer at London North West. So the paper includes our model employer goals, which are focused on achieving equity in terms of the representation of our Black, Asian and multi-ethnic workforce at senior levels compared to the overall representation in the workforce. So you will see that currently across the collaborative, we have 61% of our workforce, very diverse, coming from these backgrounds, but in all of our organisations, we need to improve representation at the bands 8A and above to VSM in order to achieve equity. And there's variable distance for each of the trusts, but at all bands and for all trusts, we need to improve that representation. And there is active work to look at the steps that we can take to improve that direction of travel to achieve our targets by 2025.
Thank you, Tracy. I think it's important work and something that we've only just started to measure and bring forward, and start by exposing the gap. So questions, comments? Please, Pat.
I was just looking at it, and it's always challenging, but I just wondered, and I'm not in the People Committee, so you might be already doing it, whether you've got a staged approach to it, because your biggest gap's obviously the most senior, and sort of you're not going to jump somebody from the bottom to the top. So I just wondered if you've got an action plan looking at, and then with timescales about how you're looking to address it. Each trust has an active equality plan around improving its res goals, which is very much focused on inclusive recruitment, to making sure that we're actively looking at any disparities at each stage of the recruitment process. But your key point about how we change our representation at the top is actually that we need to start at the middle. So we know that representation drops significantly from bands 8A and above. However, that it doesn't just start there. So we need to look at what we're doing for what I'd like to describe as our future leader grades, which is our band 6 to 7s as well, because we clearly have the talent pool. It's just where it is. So we need to make sure we have realistic programmes to progress and support career development for those staff that are in those transitional grades.
Thanks, Tracy. And we are going to talk more shortly about our EDI strategy, and I know AJ is going to introduce some work that he's been leading for us. Any other questions on the workforce piece? Nope. Good. Thank you very much indeed. Have I missed anything off the operational report? Finance. Finance. I knew there was something. I always forget finance. Thank you. Are we with you, John?
You're with me, thank you. So, hello, I'm John Bell. I'm the Chief Finance Officer for Hillingdon, here representing all the other CFOs. So, just in terms of finance, so the numbers you have here in front of you are the performance as at month 11, but I can also submit to the performance, give you an update on where we are with the financial performance at the end of the month. So, we all closed down at the end of last week. And I'm pleased to say that across the Acute Provider Collaborative, we've reported a break-even position. Within individual organisations, both Imperial and London North West are reporting break-even, and then between Hillingdon and in Chelsea and Westminster, there's a deficit being reported at Hillingdon in relation to a particular transaction, and there's an offset at Chelsea and Westminster. So overall, the whole Acute Provider Collaborative has delivered a break-even position, which is has not been easy. And last week was quite a fraught week, I think, for most organisations, but we got there. So that's really good. I think the drivers of sort of where we were underlying that position are the things that we've set out in this report that we were reporting at month 11. So clearly there's still an issue around, while I think CRP under delivery would have been mitigated quite substantially by the year end, there'll still be a lot of non-recurrent in that. We were mostly mitigated for the industrial action costs through a combination of national funding and additional performance on ERF, which was used to offset some of the industrial action costs. We've carried some excess inflation costs into the position as well at the year end. On income overall, we've done really well on income. Elective recovery income was at this point was 37 million over, and I think we saw some further improvements at the year end. And I think one of the pieces of work we're doing at the moment, just as we exit this year, is just to understand the exit run rate from this year, how that then translates into the plans we've got for next year. But overall, I think we've done well to achieve the break-even position. I wasn't going to say much more about the actual financial performance in month 11, but just a couple of other things around cash. So you'll see in the report here at month 11, we had about 343 million of cash across the Acute Provider Collaborative, which was a reduction of about 66 million from the beginning of the year. And that's predominantly driven by things like the underlying I&E position, some of that being supported with non-cash benefits, but also spend on capital and an increase in debtors as well. And then on capital, just to say where we are, so we have a target, obviously, for capital that we all have to meet. It's measured at an ICS level. So across the Acute Provider Collaborative, we had an overspend of about £1 million, which we used some of the underspend that was in the ICS. So actually, overall, the ICS has broken even, and we've all made sure that we've effectively used the full available capital across the ICS at year end. And I'll just pause there. I'm happy to take any questions.
Thank you, John. And let me just echo congratulations on us getting it to a break even this year. That is no small achievement in the NHS's current financial position. So, and I know it was nearly all the work of the finance directors, but anybody else who was involved in delivering that, congratulations as well. Any questions? David, please.
John, thank you. And obviously, finance, thanks very much. It clearly is, and operational folk, an excellent performance. Can we just share with the public the check and balance that we have in place, that despite the pressure on the finances and how very well people have done, that is not at the expense of patient safety? Could somebody just comment on that, please?
Leslie.
So it's a very good question, actually, and it's something that we think about all the time. And I'd like to think that actually the operational performance, the quality performance absolutely speaks to that. But it's that constant triangulation of how we're spending money, making sure that we aren't making cuts in a way that will endanger patients. And I think we've taken the view this year that actually what we really wanted to do was treat as many patients as possible, given the year we were coming into and COVID that we were coming out of. And in a way, the commitment of our staff to do that has actually helped underwrite our position this year, and in a sustainable way as well, which is a really important thing. But I just wanted to make one other point, which was to say this has been, though, last week was a really tricky, challenging week to get to a position that we got to, and it absolutely speaks to the commitment to individual organisations, but the commitment to the collaborative in a way, because it seriously has not been easy, but we've done it. So a really big well done to the CFOs, but to actually the operational and clinical staff who've managed to carry on doing all the things they needed to do while that work went on.
Thank you. Any other questions, comments? Thank you. Just to echo Leslie's point on, because the question gets asked a lot, including at chairs meeting by other chairs, about the balance between quality and finance. Now, clearly with more money we could do more, but 30 years in the NHS, I would say well-run organisations manage their money well, they manage their throughput well, and they manage their quality well, and poorly run organisations tend to have no grip on any of them. So it is, in my experience, a false dichotomy between we can see more patients or we can manage our budget. If you're, as I think we are increasingly managing ourselves well, we ought to be able to treat more patients and to know where the money's gone as well. And I think that's tributes to people that we have seen most of the indicators going in the right direction and the money coming in where it needed to be. That is a significant effort from staff. So thank you. Okay, I'm going to move us on now to the collaborative committee reports, and I'm going to start with Steve and quality.
Okay,
Item
thank you.
4.1, if people are following us on the agenda.
Yeah, so I'm Steve Gill. I'm the Vice Chair at Chelsea and Westminster. I'm a non-exec on Hillingdon, and I'm the Chair of the Collaborative Quality Committee. So you'll see from my report that there are 6 escalation items that came from the Quality Committee to the board in common. A couple of these have been mentioned as we went through the quality and performance report, so I'll touch on them briefly. Never events, Alan referenced, and we do have a review of never events that is being conducted as we speak. This does link to the 24-25 quality priorities for the collaborative, and the majority of the never events that we've seen have been related to invasive procedures, and we're looking specifically at the learnings from that. We have a concern, a significant concern about mental health patients and where they're being treated. We're seeing increasing numbers of mental health patients being treated in acute settings, not necessarily appropriate for those patients, to say the least, and not necessarily the best in terms of the amount of training that we have to provide for our staff to be able to deal with this. So we've got increasing numbers being seen in a unsuitable setting, which is an issue that we're raising across the collaborative with the ICB and with the mental health trusts. Infection prevention control, Alan also touched on. All of the trusts are above the threshold, but when we went through the review at the local quality committees and at the collaborative quality committee, we did get assurance that robust controls are in place. We are in the middle of the transition from the serious incident framework to the patient safety incident reporting framework, What we're looking at is the grip and control as we progress from one methodology to the new one. We have a soft launch underway from the beginning of April, and we're carefully managing that transition with reviews in detail at each of the individual quality committees. We have the impact of industrial action, which has an impact on both patients and on our staff. There were an increasing number of SIs that were reported from August of 2023, and we are looking at what is the cause for those SIs. So there's a separate review going on there. And the final one, which I'd like to just open up in a second and ask Patricia to talk about briefly, is the Hillingdon maternity. This is referenced in a number of places in the papers. There was a CQC report on maternity that was published in February, and as a result of that, there's a number of specific actions that are being taken across the collaborative and specifically in Hillingdon to drive an improvement programme across culture and stillbirth reviews and in response to the CQC report. So I will stop at that point, and perhaps Patricia, you'd like to add a few comments?
Yes, certainly. Thank you, Steve. So I'd like to formally report to the board that, and this is mentioned in my report later, so I won't cover it later, is that in August 23, our maternity services were visited by CQC. It was part of a national programme of inspections where they've been inspecting all maternity services in the country, and rightly so in response to concerns raised by the Ockenden review and reviews of a number of services countrywide. We had the inspection report on the 14th of February 24, and disappointingly our rating moved from good overall with outstanding for well led to requires improvement overall. So they only inspected the safe and well led domains. We had 14 must do actions and 11 should do actions, although there were actually no enforcement notices or specific sanctions for the service. And I'll ask Sarah in a minute to come in and just talk a little bit about where we've got to on the must do's and should do's. The CQC inspection happened at a time when we had already started to identify some concerns about the maternity service overall, and had commissioned as part of a maternity and neonatal improvement programme a number of external reviews looking at the culture in the unit, our stillbirths, which you can see we've monitored as part of the Board in Common performance report. And that piece of work now is ongoing. We're determined as an organisation that we will very quickly move back from requires improvement and actually aim to be an outstanding trust, so that we become an outstanding trust in the context of outstanding for the APC overall. That programme of work is being led by Alan and Sarah, the Chief Medical Officer and Chief Nursing Officer. And we will be monitoring that very closely through our assurance and governance processes within the Trust. So I don't know, Sarah, would you like to just update us on where we've got to on the must-dos and should-dos, please?
Please, Sarah, and introduce yourself so people know who you are.
Thank you, Patricia. Thank you, Chair. I'm Sarah Burton, and I'm the Chief Nurse at Hillingdon Hospital. As Patricia has outlined, we had the CQC visit and report, and as she described, we had no enforcement notices, but we did have 14 must-do actions and 11 should-do actions. Since receipt of that, we've developed a robust action plan, and under the must-do actions, we have 76 sub-actions, and under the 11 should-dos, we have 56 sub-actions, and of those, we have 22 of the 76 actions complete and 17 of the 56 now complete. And other key milestones have also been completed within that. We have to note air conditioning units now installed and are operational in our midwifery-led unit and all our clinical areas. and our emergency medicines are now available on all the wards and treatment areas. As Patricia referenced, we've had external reviews commissioned and are now complete and going through our internal governance processes for stillbirth, governance and culture. We now have installation of security swipe exit systems on all our maternity areas, and we're currently in the process of strengthening our midwifery leadership roles. And as Patricia also referenced, all these CQC actions are sitting in a wider maternity improvement programme. And happy to take any questions. Thank you.
Great, thank you very much, Sarah. Any questions, Linda?
It's more of a comment than a question. Just to say that from the Quality and Safety Committee point of view, I'm Linda Burke, I'm the chair of that committee in Hillingdon. We obviously will be giving considerable scrutiny to those actions. And just to highlight a couple of things, obviously there are many things, but a couple of highlights for this. One is that making sure from all these reviews, and it's very positive that these reviews have been initiated by the Trust, that we find a way of making sure that the key actions are very clear, both to the board, but more importantly to the staff, so that there is a very strong focus on the most important things that will make the most difference to the patients. And secondly, that we have very clear leadership in terms of both of the Trust and executive presence in the unit, but also around the medical and midwifery leadership within the unit, so that we can be confident that the presence there is actually taking the unit forward in the way that we want. And last but most certainly not least, we're doing a robust review of the data, so that again we've got confidence that we have real assurance of the data that we're seeing, and that we have good understanding of where we need to focus our actions.
Thank you, Linda. Any other questions, comments? Patricia, and then I'm going to come to Steve.
So sorry, I just would like to add the other thing that is very important is that we hear the voice of women, because we have a good, a very proactive Maternity Voices partnership. But we're very clear that as we take this work through, it's really important that we engage with our local population. Our population has changed, and it's important that we make sure that our services are tailored to that population. So I just wanted to make sure that was clear.
Good point. Thank you very much. Steve.
So I'll close it with a couple of points. So the first one on the Hillingdon maternity escalation, it will obviously be monitored in detail, as Linda says, at the Hillingdon Quality and Safety Committee, also via the Hillingdon Board and at the Collaborative Quality and Safety Committee. So we'll be looking at multiple areas of monitoring the action against the action plan, but also help and support, because I think there will be help and support required both locally and at the collaborative level, and potentially at the national level as well, to ensure that we move as quickly as we can. My last point would be just in reference to what David said about, and your question was around health and safety, but one of the things that we are doing in the Collaborative Quality Committee is we're taking all of the annual reports. We're looking at how do we make them comparable, and how do we standardise them, and how do we embed the learnings from them, so that we pick up across the collaborative the levelling up aspect of this. So there are a number of annual reports, and health and safety is a very good example. Thanks.
Thank you. Bob, did you want to come in?
Yes, please. So extremely helpful report, very clear on the escalation points. But I was taken with Steve's comment that spoke about our general concern across the collaborative of the mental health issue of staffing in our units against what's happening with mental health staffing per se, and taken that that these are conversations that are active in the ICB. So later on we're going to talk about operational planning,
the issue will still be relevant for us in 4-5. I just wonder, could you give some flavour of how these conversations are occurring with partners, to give us some confidence of recognition, I suppose, in other places?
Thanks, Bob. Yeah, Leslie.
Yeah, so thank you. So I think that obviously they are conversations that take part.
Leslie, can you describe what the thing is that we're talking about here? Because I think we're slightly in code.
So there's two things. Yeah. So what I'm talking about now is that there are patients who have mental health needs, and they are being brought to A&E departments, and they are then also at times being admitted into physical health wards. And that means that staff who are normally looking after patients with physical health needs may be being asked to look after those patients, although we do use our own mental health nurses as well. But what we would really want is that patients who need acute mental health services are seen in their most therapeutic setting. So two things I would say. First of all, about 50% of patients who are admitted do have physical care needs as well, and it's really important that they have absolute equity of access to those services. The second bit is that actually, whilst those needs are being addressed, their mental health needs are being addressed at the same time. And when they only have mental health needs, that they are taken to the most therapeutic setting as quickly as possible. And there are delays about that. In terms of the question about how we're having those conversations, so we have those conversations at the Acute Collaborative Executive, chaired by Tim. I sit, as does Claire actually, on the ICS Leadership Forum, and we take nearly every week those conversations. And at times there have been some improvements. What we've asked for now is a strategic plan for a sustainable improvement, and we will bring that back here, Bob.
Thank you very much. One very last, thank you for raising it. I think the real concern is that we're seeing a decrease in capacity in the mental health trusts, and the implication is that we're, from an acute provider collaborative point of view, we're quite rightly picking that up in a sense, in that we have to be able to, and it's appropriate that we do treat those patients. But the unfortunate thing is that they're not necessarily being treated in the correct setting.
Leslie, last word on this.
Far be it from me to represent our mental health colleagues. The strategic intent is that more patients with mental health needs are looked after in their home setting with community support. And the difficulty is always that transitional period between if you close something, in this case beds, or you curtail the number of beds that you open, so you don't open as many as we might argue they need, whilst that transition of getting staff trained to look after patients in their own home. I think we're in that period at the moment, and that is always a tricky period. But just to go back to, we need to those patients right at the centre of everything that we do. But just to reassure the board and everybody who might be listening, is we do continue to provide those patients with the very best care that we can. It's just that we think we can do better as a system. So thank you.
Thanks, Leslie. John, can I come to you for the Learning from Deaths report?
Thank you. Yes, you can. I'll take the report as read, but the main highlights this month, mortality rates continue to be lower than expected, which is obviously good news. And I think the main work of my team and colleagues has been around triangulating all the things that we've been talking about and ensuring that that harm is generally low. And I'm pleased to report low levels of harm again from what we call our level 2 mortality reports across all the organisations, which is where medical colleagues go through and scrutinise deaths to look for harm. And low levels are obviously a good thing there. There were no new improvement themes noted from the additional scrutiny, which we also do now on a quarterly basis, of any spikes in mortality. And when I say spikes in mortality for us as a collaborative, those are generally things that are not truly spiking, but just where we're looking and doing a scanning ahead to make sure things don't occur. Also, we've discussed previously here palliative care coding variability, and we've taken that forward over the last quarter since we last met in London North West, where the palliative care coding was noted to be low. It's currently making changes to their methodology, which we will look to seeing the effect of in future months. Finally, to note, there was one case of suboptimal care, which again is very low, and that was at Imperial from one of the reviews, and that's undergoing further examination. And then the final thing to note in this report was the first steps, and I say first steps because it is early stages in looking at our ethnicity of deaths. This time round, we have managed to report the ethnicity of the deaths, but that in itself is really not meaningful. And the additional work that we're doing in the coming weeks is to look at the denominator so that we can then start to make some proper analysis of ethnicity regarding mortality. Thank you, Chair.
Thank you, John, and thanks for bringing that point out, because the point about the table on 4.8 is it's only relevant if you know what the proportion of the patients in that demography is, to know whether the death rate is higher than you would expect or lower than you would expect. So it's great we're starting to get the data, but next time we'll be able to interpret something from what we're seeing. So that's good. Any questions on this report? Good. Thank you. Thank you very much for that. Thanks for that, John. Okay, moving us on to the Collaborative People Committee, and it's over to you, Mr. Moss.
Thank you very much, Matthew. So my name is David Moss. I'm now the Vice Chair of London North West, and I have the pleasure of being the Chair of the Collaborative People Committee, which I'm just going to share with you a few highlights. You would have seen the report in the papers, and most of the report is really just a summary of what folks have already said in this meeting. So that's actually very helpful. They're all singing from the same tune. Just to emphasise, there is a lot of work on the agenda for equity, diversity and inclusion, and AJ, on behalf of AJ and Sim, will talk about some specific actions on that shortly, in addition to what Tracy's already said. Pippa mentioned earlier that we got the staff survey results came through, and all trusts have performed relatively well in the staff survey. There are some areas still to work on, and bullying and harassment is certainly one of them. Our staff are telling us that that's still an issue, and that's something we're going to be getting to grips with. The other thing is our glass is half full. We've got just over half of the staff telling us what they think. But that also means we've almost got half the staff who aren't telling us what they think. And so the more we can encourage people in this forthcoming year to speak up and give us their opinions, the more we can do about their comments. A couple of other really quick things, if I may. We received an update on the delivery of the workforce priority objectives. I won't be going through those, but we did get a thorough update on that. We also received and noted the individual trust people committee reports. A key risk to escalate is that the need, a new one, the need for a sustainable and affordable workforce plan, and one that we can achieve a run rate of sustainably. That's been a challenge for the 4 trusts as they report into the collaborative. And when we look at the business planning for next year, that's a vital KPI that we need to keep an eye on. And then just finally, we were going to look at the terms of reference for the committee. And we had a good discussion. Those terms of reference will be formalised soon. But we were very keen to use the collaborative committee to look at forward thinking for people rather than looking back. Imagine the analogy, if you will, of a windscreen and a rearview mirror. We felt that the local trust committees should look more in the rearview mirror, getting assurance on what has been done, but the collaborative committee needs to look more into the windscreen about what are those exciting things we can do to improve our employee value proposition and make our collaborative the place of choice to work. So with that, Chair, I'll keep quiet. Thank you.
Great, perfect. Thank you for that. David, any questions? You're in my blind spot, so
Yeah,
thank you. So
that-
keep shouting at me if I miss you. Yeah.
No, I was just thinking when you were speaking there, David, about where does the NHS people plan fit into all of this? Because there was a big sort of announcement made about it all, but it's sort of
Yeah.
I'm not sure where it filters down and how we can engage with it.
No.
Okay, I'll try and, yeah. So when I get it wrong, Pat, they'll correct me. But I think if we look at the, give me just a minute on my paper. If we look at the delivery of the workforce priority objectives, within those are in fact key parts of the people plan. I'm now just going to check whether I've said the correct thing.
I feel like I'm at home.
This is where our executives provide assurance of our needs. Yeah, that's,
So yes, you have. So, but just to be completely transparent, so we are all 4 trusts are signed up to the People Promise. The People Promise is the implementation plan of the People Plan. It's come with a small amount of funding this year. Imperial were actually a pilot last year, and the other 3 trusts have now become a pilot this year. So that's about the delivery arm of some elements of the People Plan. We've then aligned the People Plan priorities with our own APC workforce plan, and as we start to develop the trust's workforce plans as well, it will completely align down from, if you like, national to APC to individual trust plans, so it's completely aligned in the layers.
Tim.
Thanks. I think the national workforce plan and its aspiration and where we are now are pulling us at the moment in 2 slightly different directions. And so I think there's a bit of work now to acknowledge the fact that we are currently in a situation where, on the one hand, we want to recruit many, many more doctors, nurses and other healthcare professionals, and on the other hand, we're saying we've got a set sum of money, we've got to get our workforce down. I do think David's point about looking forward is very important, because I think we as a group need to take a view about how we can deliver the aspirations of the workforce plan in terms of building the workforce, thinking about new roles, thinking about how we pull all that together across the collaborative. But I think we've got to recognise that probably this year and next year there's going to be quite an uncomfortable tension as we work through that.
Thank you. Kevin, you momentarily had your hand up. Did you want to add something?
No, I think Pippa covered it. Thanks, Matthew.
Great, thanks a lot, Kevin. Hey, Saman.
Hi, Saman Dalby, Chelsea and Westminster Hospital. David, this question about representation of BME people, it's grade 7 to 8. Don't you think that the bar is too low in terms of measuring it? Because if we were to look at the grades above 7 to 9, I think you would find that the representation is far lower than that. So is it not a case of statistics and damned lies? Thank you.
Thank you, man. I think you're spot on. And hence the reason why we've got to use this committee to look forward on what it is we want, rather than look back on what it is we've had. So I couldn't agree with you more.
Thank you. I think that is a neat segue into the EDI paper. Do you want to introduce it, Pippa, and then I shall ask AJ to say something?
Happy to. Thank you. So this was an action that was taken away from this board, I think 2 meetings ago now, where we were tasked with setting up a task and finish group to make some recommendations to the board about how we deal with some of the EDI agendas that we talk about, and how we make sure that as a board we have a robust action plan so we can progress some of these. So we established a task and finish group, very ably chaired by AJ and Sim. It's got representation from all 4 organisations, and they're not the normal voices, actually. They're very different people within the organisations. It's been very vocal. It's been very insightful. I think AJ and Sim have had their work cut out chairing it, and it's been quite interesting to watch. But actually, it's great to hear some different voices, some different views, and we have very much said to them, what would you want your board to do? What would you like to see your board members do differently? And how do you think we should address the EDI equality plan from a trust board perspective? So the main part of the first 2 task and finish groups was to deal with the the Workforce Agenda 1, which was to make recommendations for all board members to have EDI as part of their portfolio and actively engage with an EDI portfolio across a board setting. The second part, which we're now working through, is how we do the wider equality piece around patient inequality, as well as the wider staff inequality, and that's what we're working through now. So I'll hand over to AJ so he can talk through where we've landed with the first task.
Thank you, Pippa. AJ Mehta, non-exec director with the Chelsea and Westminster and London North West. I think Pippa's kind of outlined what the group has been set up to do. So we met in, I think, initially in January to set the terms of reference. We're working towards 6 high impact actions. So the first one being the one that we're discussing today, which is really around setting objectives for board directors, executive and non-executive. And then we'll be looking at recruitment practices, inequalities in pay, looking at the variations we've got around bullying and harassment, violence and aggression, for example. We're also looking at sort of international recruitment and the experience of staff who come from overseas to work for us. So we have got our work cut out. The objectives that we So basically, these are a set of recommendations that you can see in front of you in the papers, and once agreed, the objectives will form part of the directors' objectives. Directors' objectives in their appraisals. I think we will look at the next 5 actions to bring back in July to the board in common, and by the end of the year, the calendar year, in December, we will be in a position to assess how we've been doing in terms of implementing some of these objectives, and also sort of setting the scene for the following year. So the slides should, hopefully, the slides are self-explanatory. So we've got one common objective across the directors, so executive and non-executive directors. Really, this is about culture and shifting the conversation around the table, and not being afraid to raise the head above the parapet to ask the difficult and different questions around equality, diversity and inclusion. And also, it really is about giving the directors a choice of objectives that need to be set. Now, it's unquestionable that people around the table and the directors who've joined us remotely are completely committed to this agenda. But often we find ourselves being quite busy and doing other things. And really, one of the challenges is around having objectives to be measurable. So what can we say about the end of a particular period that we've achieved some things? So there's some examples here with the common objectives and also the individual objectives for the non-executive directors, for example. Now, these objectives, the examples here are really around the collaborative committees and the kind of discussions that need to take place in those committees. And those are the responsibilities of those non-executive directors. So, whether it's workforce or finance or digital, etc. And then with the executive directors, there are some objectives as well. So really, some of this is also about pairing directors with members of staff. So for example, to help deal with the issues that Aman, you've just raised around some of the inequalities around, with the MEG stats that we've got, which really we need to really address. So I don't want to say any more, but I think it might be more interesting to see if there are any questions or comments from people. But Pippa's absolutely right. It's been a really vocal group. We've tried to create a safe space for people to be really honest, and we've got some patient representation as well. So it's been really, really good.
Fantastic. Thank you, AJ. Carolyn. You're on mute at the moment.
Can you hear me now?
Yes.
Yeah. Okay. Thank you. So I want to say a really big thank you to AJ and other colleagues for doing this piece of work. I think it's much better, to be honest, than I thought it would be when we were talked about, and the objectives that we're given, I think, are very good. I do, however, think we really need to concentrate. It's not in here on the issue of data, because at the moment we're just measuring ethnicity. We're not measuring local populations, and there's no we're not able to see where it's the disproportionality we should be looking at as much as anything, and we're not doing that at the moment. And then my other point is, I think that's a big issue for us, and I think until we do that, we're not going to be terribly effective. And then the other issue for me is, we've got here that the evidence for non-execs will be from committee minutes about conversations, and that's good, because conversations should take place and this should be a priority issue which is being discussed. But you can have lots of conversations and absolutely nothing happens as a result of those conversations. So how does that get monitored and managed?
Thank you. I'm going to take some inputs and then I'm going to come back round to AJ and be able to give some points at the end. Catherine.
Thanks very much. Catherine Jervis, Vice Chair at Hillingdon and Board Member at Chell West. So, yeah, I very much support this particular objective, and clearly leadership is very important. I've been very struck during the conversation today, getting to a sort of point, a year-end point, about what we've achieved when we've had real focus and real energy behind our priorities. And so I suppose I would really like to understand, what is our level of ambition on this particular agenda, and, will this process be ambitious, and will it set, really challenging and measurable targets for us as a collaborative? Because I feel like, perhaps, if I'm interpreting what Carolyn's sort of saying, I feel we have had a year of a lot of conversation, but not an awful lot of measurable, movement in the sort of direction we would like to go. So I think, I look forward to hearing where we've got to in July, and perhaps picking up that level of ambition. Thank you.
Thank you. Linda and Simon.
Again, agree, really good work and really definitely movement in the right direction. Two questions from me, really. One, do we feel, and does the team feel, that we're doing enough with this to address what might be our own collective unconscious biases, and how we're challenging that? Because can't really see that in there in terms of it's quite individual in terms of what we're doing. And then the second thing is in terms of how we make sure there are consequences of some kind for not achieving them. I think it would be very easy to get sidetracked by very legitimate other kinds of things that we get from on high about targets and achievements, etc. So how do we make sure that these objectives have equal weight with all the others in terms of the importance we give around achieving them?
Thanks. I've got 4 people who want to come in. I'm going to take those and then wrap it up. Otherwise, this is a topic that animates the board, and we could do this for a while. But Simon next, please.
Yeah, no, thanks. I echo the comments made and welcome it, and a comment made before. I think given that it's so vast, we need some focus. And I think my question and request really is that there is some sort of thinking about the strategic objective, like we know that we need to get to 78%. Focus on, and we talked earlier in the people thing about getting staff at higher grades. Maybe that should be a single focus. Otherwise, we could find ourselves all having very different targets and pulling away. Resources are tight in both time and money. And I just think that we should try and think about the focus when we're doing this.
Thanks. Saeed.
Thank you, Chair. If we take the recruitment process as continuing David's analogy, whether we look in the rear view mirror or we look through the windscreen, if we travel the same road, we will end up at the same destination. I think it's about being a bit more courageous and asking, how can we actually travel a different road in a different way? And of course, still be efficient and take less risk. So it's a challenging thing. Thank you.
Thanks, Saeed. Tim.
Thanks, Matthew. A couple of things, I suppose. The first thing I think is need to be clear about, I think, the timescales in which we're trying to sort this out. I think that one of the key issues for us, if, for example, if you take the band 7 and above, I think, as Tracy absolutely correctly said, in order to tackle that, you've got to start earlier in the pathway to allow and really make sure that people have got opportunities to come through. So I think there's a bit of work for us about, if you look at what you can do actually at the recruitment stage there, and we spent an awful lot of time internally, and so I've only got the imperial figures in my head, but, we've increased in the course of the last year, I think by about 3%, the total number of people from BME backgrounds in band 7 and above, and that's been through a hard process of really paying attention to groups. Now, it's definitely positive, but it feels really quite slow. And of course, if you go to the band 9s and the VSM levels, the turnover is so much less, and the number of people is so much less, that every single appointment you make becomes so much more significant in terms of your. So I think we've got to be really deliberate about working out how we do that dual-pronged, getting into the recruitment bit for the top end, but really making sure that we are supporting and driving the pipeline through, and being realistic then about what that means in terms of the timescales. First thing. Second thing, we've done a load of work around disciplinaries and looking at how people have gone into disciplinaries. And one of the really interesting things is the intersectionality between different characteristics. And I think we probably need to do some more work on that. And then the final thing, which I think is very, very important, is I think we probably, if we can, need to banish BAME, and we need to split stuff out by ethnicity, because we know that if you look at the proportion of, for example, Indian candidates that are appointed, it is really quite high and comparable to the number of white people who are appointed. If you look at black African or black British, it is absolutely not, and we need really to focus our attention on where the big differences are.
Thanks, Tim. Loy.
I think we need to look at our leadership development and succession planning at every level at the organization, and look at, what are sorts of people are putting themselves forward, how they're progressing. Unless you look at that data, you're not going to get that forward view. To what extent do we have it today, and what do we need to improve our side of that pipeline?
Thank you. Yeah, I think this is an important piece of work. It's generated big discussion here. It's been generating a lot of discussion over the last years. I think we're doing three important things simultaneously here. I think the piece of work here about individual responsibilities and building it into executives and non-executives objectives for the coming year, I think is a big step forward. We've had support the collaboratives EDI objectives as in everybody's objectives previously. This goes a whole step further than that. I think that's important. I think the point about data, I think, is crucial. You started to break out in the papers that we're seeing. So we saw the first breakdown of mortality by ethnicity. We saw the breakdown of grades by ethnicity in the model employer papers. I'm expecting by the time we come to the next category, we will see in each areas, we will see what are our priority target areas to move the needle. Built into our routine reporting, so it doesn't sit out as different. It's actually part of the way we look at how long are people waiting, how do we handle complaints, and so the key things that we think are priorities, and that will fit into the way in which we make stuff happen. To Catherine's point, so I think and I think the other part of this is then the what is the cause and effect. So if we're trying to create equity all the way up our grades, we need to ask ourselves, what are the things we need to be managing at each level? And it's not well, if we could get the band 3s right, the band 9s would solve themselves, because at each level we get a drop off, and we should look at each level where we're losing that. So within each of the groups, whether it's workforce or whether it's quality, or whether it's performance or whether it's digital or estate, I'm expecting us to now be building this into our day-to-day, our quarterly cycle of work of what are the things that are going to make a difference. And I think this is starting to pull this out. So I'm going to come to AJ for any final thoughts. I don't think we need to run through the questions and answers them because they're all valid questions that we need to take away and execute on. But they're AJ, final thoughts, and I'll come to Pip for final thoughts.
Thank you, Chair. Yeah, I mean, it's been a really useful discussion. And as you can imagine, this is what we meant about when we have those meetings, really everyone has something to say, be passionate about, and it's a really important area for us. But also each trust has its own, in talking of data, in terms of the workforce race equality standards and the disability standards. So I think, each trust has its own, should have its own EDI work that's, and EDI leads, so equality, diversity and inclusion leads. Working, and for this we've said to the EDI leads to work closely with the chairs, the workforce committee chairs at their respective trusts. But no, really interesting piece here, and it really is. This is really about. I mean, it's a huge area, so it's about small pieces and tracking change and measurable change. Having some objectives, having some accountability, and and then only in a few months' time we'll be able to tell whether this has been working or not. But it's a huge piece of it's a huge area, so we can't really answer everything. But I welcome the discussion we've just had. Thank you.
Thanks a lot. Anything to add, Pippa?
I think it's a really positive discussion. Many boards are not having these conversations, so the fact that we are is a really positive step forward, actually, and the more conversations we have like this, the further we progress along what is a very challenging journey to get equity. The key thing I just want to get agreement on, are we happy as a board that we go away and work up the executive and non-executive pairing programme? So that means we're all committed to a very informal but conversations with key members of staff from some of our diverse backgrounds, so we can have that. We're not calling it mentoring because mentoring has an official title and programme, but a very informal connection with us all as a board that breaks down that barriers of the board for a start, but also helps us springboard some of these people into more senior positions. Are we all happy that we work through that?
So can I get agreement to that and agreement to this paper more widely as now board policy? Yes? Great, good. Thank you very much indeed. Excellent. Moving on, and there I was halfway through the meeting and bang on time, and here we are an hour late, half an hour later, and I'm an hour late. But anyway, moving on to digital and data, Steve.
Right. So I'll make 5 brief points in an attempt to help us to get back on track. So at the Digital and Data Collaborative Committee, we received assurance on the stabilisation programme that we're working through following the Cerner EPR implementation at London North West and Hillingdon. That's the first one. The second one, we discussed the risks around potentially insufficient funding for ICT infrastructure and how we prioritise the risks, particularly against cyber and patient activities. That's the second one. The third one is we did agree the digital and data priorities for 24-25, and there are some concerns that we need to understand the funding against each of those individual work streams to enable us to drive them as quickly as possible. The fourth one is coming back to the discussion we just had around EDI, and the Digital and Data Committee clearly has a key responsibility about providing the data, and the speed at which that is going is not as quickly as we would like. So there was a fairly robust discussion about how we accelerate that so that we can get the right data to the right committees to enable us to do the analysis and have the conversation on disproportionality that Carolyn mentioned earlier. And the last one is we discussed the Federated Data Platform, which has been recently, the contract on which has been recently publicised, and the North West London Acute Provider Collaborative has been taking a leading role on the rollout of the Federated Data Platform. Modules, there were 7 which we're expecting to deploy have deployed and be deployed, and we need to accelerate that process as we go through 24, 25. And I could tell you what they are, but they're in the paper. Okay, thanks.
Thanks, Steve. Any questions or comments on this? Loy, then Tim.
Steve, you mentioned that there's been a budget constraint, especially around the infrastructure and some of the technology components. I was just reflecting that the tech industry business models have changed, and customers no longer have to buy technological products. It's more provided as a service, whether it's infrastructure as a service or devices as a service. I was wondering if there had been any exploration of should this be funded out of a revenue budget rather than a capital budget, and what has been the consideration for that aspect?
So yes, there were some very specific conversations about that, and what we need to do is I guess like everyone else, is we need to be able to progress from where we are now to what the future looks like, and it's trying to get that balance. The gap on infrastructure funding isn't particularly large given the size of the acute provider collaborative, but there are some disproportional areas where we feel that there are specific risks that we need to manage. I'm happy to take you through the detail.
Well, you'll be joining the committee as well, Loy, so you can you can fill your boots at the next meeting. Yeah. Tim.
Thanks. Sorry, this is slightly small print, I suspect, Steve, but just in terms of that, the EDI and the recording of ethnicity for patients, so we did a project where we got it up to over 90% by pulling all of the data from the whole systems integrated care system into Cerner. We've now got all 4 trusts on Cerner. I think we need to take away a piece of work that says we should do that across the whole of the collaborative, and that should get us to where we need to, because until we've got the data, we can't start to analyse it. And I think we should sort of set ourselves quite a ambitious target for doing.
Thank you. Trish, did you want to come in on that?
So, Tim, actually, I wrote to everybody about that, and some of your team are helping us in terms of how we can all upload that data so that we can get access to that. So it's ideally what you'd have is a flag on Cerner that didn't allow you to progress unless you filled in that data. But actually, because so much of it really should be inputted when patients see their GP, it makes more sense to bring it from the GP record. So that's absolutely what we're planning to do.
Any more questions or comments? Okay, happy to accept that report and the priorities as laid out. Thank you. So moving on to Bob and our estates and sustainability.
Thank you, Chair, and I should have done this before. I'm Bob Alexander. I'm the Vice Chair at Imperial and an ed at London North West. I'll take conscious of time, I'll take the report as read. I hope it's fairly clear. Two observations. Firstly, to pick up David's analogy, I think the committee has started to look through the front of the car rather than looking out the back. Reports that we've asked for have started to come through, and that will give opportunity through the APC executive and other committees to start planning forward around the strategic estates and some of the soft FM piece, which I think will give benefit. And to Catherine's point about the consequences of not doing things around the EDI, so we're very supportive of equality impact assessments in relevant business cases, so much so that the view would be, if you haven't done a comprehensive one, guess whose case isn't going to be considered. And I think just occasionally a bit of light stick as well as a very, very large carrot is no bad thing in driving a bit of change and focus.
Thank you, Mr. Stick. Any questions or comments? Loy.
I've been going through my induction and visiting some of the hospital sites and listening to the development plans, and I've heard that we want to build carbon neutral facilities. My reflection on that is it might not be enough to build carbon neutral real estate. We may have to think about carbon negative real estate. And the reason I say that is because there is so much more that happens in and around the trust and in our supply chain that might not get us to the net zero in time if we don't think of our buildings and our built infrastructure as net negative. And I just wanted to leave that for consideration. Thank you.
Thank you. Bob.
Absolutely valid point, Loy. And one of the very positive conversations we had at our last committee was the extent to which we will be looking for in our significant procurements to be absolutely clear about the sustainability carbon agenda of contractors and suppliers that we choose to work with. And I'm absolutely sure we'll be playing that into the wider redevelopment programme as we properly get going.
Thank you. Steve.
So, Bob, can you say a little bit more about the risk associated with the very significant amount of backlog maintenance?
It's not going down. So,
and in terms of things we can do?
Well, certainly so far as Imperial is concerned, which probably proportionately, though I recognise across the piece, no one has this easy. We have built up quite considerable contingency planning for impacts of estate failure. Probably a better way to describe it. Clearly, the Estate and Sustainability Group does not compensate for local redevelopment committee work, and neither will it want to tread on the toes of local audit committee work, where presumably specific failure or specific risk will be managed. What we will be looking through very good work that's being led by the Director of Estate at Imperial, but everybody is joined in, is the benchmarking work on what the estate comprehensively looks like, where that what opportunities that gives us, but also is there themed risk that we can do a little more collaboratively to address rather than recognising the individual responsibilities of individual bodies.
Okay, on that, you're doing very well too. I can see you shivering with enthusiasm to go. So thank you very much. We're happy to accept that report. I will move us on. Thanks a lot, Bob. And we're Catherine, Finance and Performance.
Thank you very much. So Catherine Jervis, Vice Chair Hillingdon, and Chair of the Collaborative Finance and Performance Committee. So we have heard a lot about the sort of key points that are detailed in this report, so I won't repeat those. And I guess when we met in March, it was to some degree a sort of meeting at a point in time, because we were concerned to really land the year in a positive way in terms of finances and performance, which we've heard we very much did achieve, and you know, note with appreciation that the really hard yards that our teams have you know, trod to achieve that. And the items that will follow very much around the year ahead, the business plan, where we've got to on that, both in terms of the money and workforce and operations. So we will hear about the detail of that. I think just to sort of reiterate a few points which feel worth remaking. As a committee, we're very keen to ensure that we have an increasingly better handle as a collaborative on demand and capacity and the collaborative response to that. So that certainly was a feature of discussion, and unsurprisingly, a big element of focus there was diagnostics, where our performance is more challenged, and so that was a key area to focus on. We were asking ourselves also, had we done enough on EDI? Had we sort of dropped the ball a little bit? We've got some programmes and projects which are primarily around equity of access, and I absolutely take the point around, until the data's in a really good place, you can't finesse some of the things that you do. However, I think we have a number of projects running individually in trusts which are showing us things that we can learn from. And I think we're at a point where we can sort of start to think, what would our strategic response be, and to start to sort of develop a sense of what we would do once we get the data. So certainly going forward, we have a real appetite for that. And I think, to echo both David and Bob's points about sort of which way we're looking, are we, as we move into a more established collaborative model, we become more secure to some degree in terms of the assurance activity that's taking place at individual local trusts, and become more interested in what the role of the collaborative could and should be around key areas. And so that's definitely going to be a greater area of focus as we move forward. I think the one thing that we probably haven't raised at all during the discussions was that the committee did receive the outline business case for the financial shared services, and so had a useful conversation around that, referencing some of the learning we've had from the procurement activity, and so agreed to move forward on the basis of really taking forward the learning and some of the sort of risks and problems that we've encountered, as well as the opportunities through that procurement work. So that is something for the board to note, that we're now moving into towards a full business case process for financial shared services. But there will be, I know, a great deal more discussion and seeking assurance on some of the things that I think we have found to be more difficult as we've moved forward with the procurement. So I think, Chair, those are the key things that I would like to pull out, that I know won't necessarily be picked up in the next few items.
Thank you very much, Catherine. I think the point on EDI you make is important, because I think there is a lot of analysis that we haven't done in particularly in the access space. And just linking, I think, Carolyn's point about place is particularly important here. The intersection between race and poverty, and therefore starting to look at postcodes and where health need is and how that aligns to where we deliver our services, I think is to some extent that's the ICS's job, but insofar as we are delivering our outpatients and our care, I think it's very much our job as well. Thank you. Questions or comments for Catherine? Please, Loy.
Thank you. I had a point about point 2.6 about the financial services, shared services. When we looked at the OBC in our Finance and Performance Committee meeting, the concern expressed was we didn't have clarity about what that converged target operating model would look like. And there is a bit of work required to clarify that target operating model, because you could end up building a very detailed business case for something that might not actually work in practice. And then you just keep justifying a flawed design. Having been involved in a lot of shared services projects in the past, successful and unsuccessful, arriving at what that future way of working is going to look like, the organization design, the level of activity, the staffing model for it, is really crucial before you get too deep into a full business case.
Thanks. Thanks, Lloyd. Did you want to come in on that, Leslie?
And that's what we'll do.
That's what we're going to do?
Yeah.
Yeah. But I think it's, I think we also had the profound thought at the committee as well that these things were better executed well than badly. Any other comments or points? Okay, thank you very much. Thanks for that, Catherine, and I will move us on to Jonathan Reed and the finance report. Have we done all of that? We've got no more. Okay, thank you.
I was going to say we've done the month 11. It's the second next item on the agenda.
Are we happy? Very good. Tim.
Sorry, this is me being retentive in a gastroenterological sort of sense. I just think the dates on the cover sheet, I think, are wrong in terms of the report history. I think they haven't been updated since the last time this came to the board in common. Sorry, I should have spotted it earlier, I guess.
Thank you. That
We
sounds
just
like
need
one
to
for you,
correct
Peter.
that.
Thank you. Very good. In which case, I will move us on to business plans. And I think, Leslie, you're going to lead us through this.
I am, and in some ways this is probably one of the most important things. So it's just a sort of pay attention now, if you don't mind me saying, which is, so we're going into the next year and it is quite a tricky a year for us to go into. And this really does play to that balance between the amount of work that we've got to do, so the numbers of patients that we need to treat, the meeting of the national targets, and we now have the national operating plan, and there's some refinement going on there, but I can't think that it won't be pretty similar to what we've been asked to do this year. So it's really a continuation of that with some minor amendments, and to do what you would want us to do in terms of continuing to improve the quality of care we deliver, and to do that within a very, very tight financial envelope. And so if the CFOs and their associated people weren't grey before, by the end of next week, when we need to have settled this, so by May the 2nd, this has got to be a done and dusted plan. I think it's May the 2nd, I could be wrong. So there's a heck of a lot of work going on. So I don't know, John, am I handing this over to you and then you'll coordinate that with the rest of the team? That would be great. Thank you.
Thanks.
Thank you very much. Yes, so if I'll just give you a little bit of a summary of where we are. I mean, the paper you have in front of you here is what we submitted on the 21st of March, which was effectively the draft submission, and actually was submitted before the national guidance came out, although in reality the national guidance didn't change much of it substantially. We have, as of last Friday, the ICB have presented their revised financial plan. We're just working through that now to understand what that means in relation to the numbers that we put together. At the point we did this submission on the 21st of March, we were showing a deficit of 109.6 million across the acute provider collaborative, with deficits in every organisation. That was before, however, any of the non-recurrent support, the growth money that the ICB have, which was allocated out to trusts in 23-24. That was before any of that was allocated out. And there's some other changes that have been presented by the ICB from Friday that we're working through. When we take account of that growth money and we take account of those other elements of income, which are still to be resolved over the next week, I think we still end up at a position of around about 25 to 30 million pounds worth of a deficit position across the acute provider collaborative. And we're doing a lot of work at the moment. We met on Friday, we're meeting again tomorrow to try and understand what we can do to close that. And that approach consists of making sure that we've squeezed everything out of what we've already assumed. So, for example, things like making sure that we've got all the ERF income in the plans, and that we've got consistent assumptions around the level of cost required to deliver that elective recovery plan income. We've been looking across the organisations in terms of the level of CIPs that are currently in individual organisation plans, which range from around about 2.7 to 3.7% of operating expenditure, and looking at what the opportunity might be if we move, either bring everybody to the same level or go even further. There's a bit of work around understanding the true-up position. So what I mean by true-up is that, well, we've monitored throughout the year, and the variable income for elective recovery has been well understood. We don't get paid for any non-elective activity, but clearly in some organisations they have been doing more non-elective activity than the plan assumed, and therefore we need to address that as part of the plan for next year. Having said that, the source of funding for that non-elective activity is the 66 million. So it doesn't give us any extra money, but it does help move non-recurrent money into recurrent money, which is really important. And it also then helps to understand the real exit run rate from this year, because clearly some of those costs that are in our run rate are delivering additional non-elective activity. So we've got a lot of work to do over the next week to 2 weeks to try and work out how we can close that gap. We have a number of initiatives that have been helpfully identified that we're just working through. But as it stands today, we don't have an agreed plan for closing that gap. And what we're looking to do is, when we finish that work over the next week and a half, taking individual plans through individual organisational finance and performance committees. And if that's a balanced plan, then I think we're in a better place. I think it comes down to, in my view, the level of appetite we have for pushing our cost improvements further, because at the moment it's around 3.7%. That's a very challenging position. We've got about 52% identified. And I think if we, in order to close that gap, we would need to understand what our appetite is for further cost improvements. We're looking at all the collaborative initiatives that we have. We've recognised that within those there are some that just won't deliver next year, and we're working through which are the ones that we think might deliver an opportunity if we put some additional resource. And we've already had a discussion about focusing some resource in particular areas of the collaborative initiatives. Oh, somebody's trying to phone me. Somebody who I don't even recognise the name of. Yes, shall I? Just excuse me if I take a call. That's right. Yes. I didn't recognise the name either. So, yeah. And then. Yeah, so those collaborative initiatives are important, but nonetheless, they still are costs coming out of individual organisations. So it's part of the discussion about appetite for CIP. Just one other thing, just to talk about briefly, is the workforce. So there's a lot of scrutiny at the moment around the level of the workforce plans, and that the workforce plans are consistent with financial plans. So there's a bit of work going on after there was an escalation meeting, I think, with the ICB last week. I wasn't at the escalation meeting, but I think Pippa might have been. And from that, there's about 3 or 4 tasks that we're working through this week, which is to understand the reconciliation, understand how the SIPs that are in our plans relate to reductions or in staffing, because not all SIPs are about reductions in staffing. Some of it's about improvements in unit costs, for example, removing agency, but nonetheless, the SIPs will still have a level of staffing reductions, and making sure that we've got a consistent approach across all of our organisations in terms of the level of over-establishment that was in the first draft of that plan that was submitted a couple of weeks ago. I'm probably going to pause there. I think we're I think essentially there's a lot of work to do. There's a lot of work that we hope will improve and close that gap, and we hope to be able to get to a position where we've got a break-even plan. But at this stage, we aren't there yet.
Thanks, John. Leslie. Microphone.
My expectation that we will get to a position of a deliverable plan, but for every organisation, and this is the message in here, is for the execs and the non-execs to have a review of that plan that says, do we actually believe this is deliverable, and how are we going to hold ourselves to account from the very beginning of the year? Our problem is we will already be in month 2 as we bring this plan together, and so that delivery of run rate as much as CIP is a really, really important message, but this will be a pretty challenging financial year. And just to remind everybody, there is quite a lot of, but a differential amount of unearned income or discretionary income that's in there. As John said, we are doing our best to get as much of it into resilient, sustainable income as we possibly can. But we ourselves need to be thinking about how we're going to use that income and also that opportunity, frankly, that the collaborative gives us to work in a different way.
Yeah, thank you, Lizzie. I want to say we have taken this through all of our local F&Ps as well. All of the local F&Ps have said our expectation is those individual trusts will get themselves back to break even. I'm not sure the question, what is our appetite for SIPs, is the right question. Our appetite is for plans that are going to be delivered, and that those plans will add up to break even. So, and some of that, whether that's reflected in, I'm happy for you to be as brave as you like around the SIPs, so long as you're going to deliver them. What I don't want is SIPs that we're not going to deliver. So, I think that's questions, comments. Catherine.
Thanks. I'd like to just explore a little bit more around our understanding where we are on workforce, because obviously sort of SIPs are hard earned and require a level of investment, and there is a challenge that I think we've had iteratively over quite a protracted period about, do we have the right workforce? And so I'm not absolutely clear from reading the papers what we think the answer to that is. Is it that this is an ongoing process and we just don't know at the moment, or do we think there isn't much more of an opportunity than is currently articulated in the paperwork?
And Tim might want to say something. There are pretty challenging ongoing discussions going on about this, and there are differing views, and there will be a bit of we're going to have to take some out and we might need to put some in, actually. You know, I think that goes back to what it will be different in each trust about what you need to use. The issue about the workforce is it's a tool to point you to say, actually, let me stop there and let you do it.
How do I take over from that?
There was
okay.
a comma there, so you know you feel free.
Okay, right.
No.
So, I mean, if you were Steve Bloomer, and Steve Bloomer's rightly challenging the CFO for the system, that 70% of our cost is staffing. So if we are reducing our cost base, that clearly is going to come out of staffing. I think we all recognise that. This isn't, just so everybody is clear, this is not about taking out substantive posts. This is about being more efficient in our staffing model, using less reliance on high-cost agency, running our elective lists on high-cost waiting list initiatives, and be more efficient in how we are providing a service. So this isn't about taking out substantive, this is about an efficiency plan. And you have to remember last year we had the cost and in our staffing base of covering industrial action. We are planning for no industrial action this year. That's how we're setting the plan. So, you know, there are some easy movements we can make in that, and we need to work this around efficiencies, not posts coming up.
Tim, then Martin, then Virginia.
Yeah, thanks, Matthew. So, I mean, I do think it is slightly trust dependent. So I think, you know, what your level of bank and agency usage is now will determine what scope you've got to move. So I'm sitting looking at 1.5% agency use. I mean, we'll get that down possibly a little bit, but it's not going to be a big win for us. I do think there's a process we've all got to go through, which is to look at the business cases that we voted in over the last period of time and what posts went in with those, and just to take a very hard-nosed view of whether they have delivered what the expectation was. And if they haven't, then we're going to have to make a judgment about what to do with them. I think that we can do reasonably speedily. I think there is probably a second piece of work, which is a more complicated piece of work to do, which is a sort of zero basing exercise, which is to say, actually, if you go round all your services and you look at best practice, can you demonstrate that your staffing in each service is best practice? Now, in terms of our inpatient areas, I think we're pretty clear because, you know, we all use the Safe Nursing Care tool. We know what our nursing establishments should be, but I think for other services, I don't think we necessarily do, and I think things have sort of developed incrementally, and it's probably not a bad time to go back and look at that. So the point, I suppose, is I'm not sure we do know absolutely what the right answer is. I think there is some quick stuff to do before we get the plan in, and then there is a more considered piece of work that needs to be done rapidly but won't be done immediately.
Thanks, Tim. Martin.
So I'm just reflecting on this conversation. It strikes me that what we are thinking about is how to do what we currently do even better. Whereas if you, for example, I'm in the north of England at the moment, and they staff things entirely differently. So it's not like they're doing the same thing better. They've just had to do radically different things in order to deliver service. And that's because they can't recruit in a way that's not a problem for us in Northwest London. So I guess my question, built on something Leslie said, is at what point does the collaborative decide that it is going to do radical things about the way it delivers service and the staffing it uses, rather than simply try and make the staffing models we've currently got work a little bit more efficiently? Because I think we're getting to the point where we really need to think about how we do things differently. That there are models across the UK to do it cheaper, smarter, different people. I'm just curious when that point comes.
Thanks, Martin. I'm going to take Kevin's piece, then I'm going to come to Tim and then let Leslie wrap it up. Kevin.
Yeah, I think as an immediate response to, sorry, I'm Kevin Croft, Chief People Officer at Imperial, because I don't think I've spoken yet, but I think part of the answer to Martin is what Tim's just described. In challenging ourselves, we need to look at our design of the workforce as part of what you've just described, Martin. I think the other part of that I would add, which is part of an addition to what Tim was talking about really, is that we now are starting to get more data because we're all on Cerner about how we manage patients, and that gives us basically a workforce footprint or a fingerprint, if you like. And so we also now start to need to get into what's the intelligence that tells us what we're currently using our workforce for. Is that different to what Martin describes or in different trusts? And how do we then use that data to inform workforce design and optimizing the use of our workforce and people operating at the tops of their license? So it's a build really on what Tim was describing, as well as what Martin was describing, I think.
Thank you. Tim.
I think, Martin, I think that second piece of work that I was describing is partly that, because I think we know that we have a medicalised model of care in North West London. I think it's important that we think carefully about what our role as trainers of junior doctors is and will be as we go forward. We know that there's a move to move training posts out of London generally. I think we've got to take a view about how that then impacts our training aspirations. We've then got to look at what does best practice look like for running these services if you take account of all the available models. And then we've got to make some decisions. But I think, as I said, it's a more complex piece of work and will take a bit longer to do, but I think it will be very important.
Thank you. Professor Leslie.
Thank you. So I think, I guess what I would say is there is more work to be done on how we deliver care to patients, improving the quality of care to patients, and doing that and thinking about all the things that everybody has said to get us to a balanced plan for next year. But I'm pretty sure this is a great pace. I'm pretty sure we'll do it.
Very good. Thank you. I think it's clearly there's work still to be done. Reflecting on your point that we will be a couple of months into the year, if we are 25 million adrift on a £3.5 billion budget, that's, I think, 2/3%. We should make sure that we are delivering all of the other things that are involved into getting us to within 25 million now, while we work out how we're going to land the last 25 million. Because it's going to take all year to get this done. So thanks for this, and I think you feel the board's support. Thank you.
Can I just ask, is the board happy that Finance Performance Committee's local Finance and Performance Committee signed this off? Because we've got to submit. Well, it goes in formally on the 2nd of May, but we'll need to have agreed it at least a week before that, I would say.
Board is happy for local finance committees to sign off break-evens.
Or better.
Or better. Thank you, David. Thank you. Good. Thank you very much. Moving on to the reports from the audit committees. Neville, your valedictory.
Thank you. Well, I've got nothing to add from the report. As you can see, there are no key risks to escalate or outstanding concerns. I mean, the main characterisation of where we are is we've been well established with the new external auditors, ASETS. Our next meeting is on April the 30th, where we will be looking for assurance as to the progress made on the programme management about preparing the year-end accounts and the engagement with ASETS and the state of preparing year-end accounts and their external audit. Apart from that, we will also be expecting to get the final 4 internal audit reports tabled at that meeting for review as well. And that's basically where we are. So far, so good. And of course, I'll be handing over the chair at that meeting to the new chair, Vanita, who is on this call.
Thank you very much, Neville. Thanks, and thanks for all of your work on that. Aman.
Thank you, Chair. There are no points of escalation. The report on the audit report on contracts management was not particularly brilliant, but I'm not too worried about it because it's easily fixable. The issues revolve more around completion of paperwork than anything else.
Thank you, Aman. Nick?
There were no key points to escalate. Progress on the external audit is going well. If I might, Chair, I just thought I would report very briefly on the Collaborative Audit Committee meeting. The chairs got together.
Very good.
There's nowhere else on the agenda for it. Some of it was discussing the governance reports coming later, so I won't take that on. But the other thing that we looked at was the development of the shared BAF, Board Assurance Framework, for the collaborative. And Peter and Dawn and others have started work on that, and it's very much work in progress. But what we're looking at, which will be linked as it develops to the collaborative strategy, is developing an understanding of risks that are genuinely system risks that are shared across the collaborative, and that will be the prime focus of that assurance framework. There will be some coverage of risks that we identify are held by each of us as individuals, but we all have the same risk and therefore has a collaborative relevance. And there may be some identification of what are individual risks to individual organisations, but there is very much a collaborative solution too, and therefore it impacts on the whole collaborative, although not everybody will share the risk. And that's what we're seeking to do. I think one of the things that may develop out of that, and this was a very helpful point, Benita, with her experience chairing an ICB audit committee, is also we need to understand the balance between what are APC system risks and ICB system risks, and how our relationship between those two will develop over time. But that's work in progress, which we discussed as audit chairs, and we'll keep up.
Great, thank you very much, Nick. Excellent, very good. And Baljeet. Right, we may need to. Is there anyone else here who was on the? Bob, were you at the meeting? Will you report on Baljeet's behalf?
I will, I can. I mean, it was I mean, nothing,
microphone, Mike.
I mean, nothing. Sorry. Someone needs to come off. So for the record, I sit on the London North West Audit Committee. There was nothing to escalate particularly. External audit is going well, as we would expect. There's a very good working relationship between the finance team and the externals, which helps immeasurably. We had a good conversation about board effectiveness, or board committee effectiveness, and a few things that we will look to develop in 4.5, not least of which will be inviting chairs of committees to audit committee to talk about their risk and assurance processes, which is starting to be a common bit of business across all four, and I think is a good way of getting committee cohesion, and we might touch on that when we talk about the governance review later on. So I'll take any questions, but I wasn't going to raise anything else. Thank you.
Great, thank you. Thank you, Bob. So let's move on to the Peter and the revisions to the acute provider collaboratives governance arrangements.
Thanks, Matthew. I didn't introduce myself earlier on, so Peter Jenkinson, Director of Corporate Governance. So the paper in front of us today sets out the proposals for the next stage in involving the collaborative governance arrangements for the four boards to approve. Members of the board will remember that when we set the collaborative of we committed to the fact that this will continue to evolve and we'll continue to learn. And we recognise that the value of bringing the four boards together as a board in common, as hopefully we've demonstrated today. There was also then the sort of the counter argument to that was there's a risk, potential risk around the lack of local oversight and engagement. That was, and you remember from the last the January board in common, we saw the findings and recommendations from the internal audit review, which bore that out in terms of one of the areas that they highlighted was that level of local trust, oversight and engagement. So we've reviewed various options as to how we might strengthen that level of our governance arrangements, and the proposals in the paper are to remove the non-exec triangulation meetings, the quarterly meetings that we put into place originally to try and mitigate the risk around local understanding of what was going on from the board, committees, etc., and to replace that with a standing committee of the trust board. It will be for each of the individual trust boards to agree the terms of reference for those standing committees, but the proposal is a standardised or common elements to each of those, which include a commitment to publishing the papers in public for those standing committees, so there is public transparency around what goes through those. Formal reporting from those standing committees to the four boards at this meeting, and some standardised agenda items, and of course membership will include the board members of each of the individual trust boards. As part of that work, and we've socialised this fairly extensively with non-executives and executives, as part of this work we recognise the potential impact on time commitment and the rest of the governance arrangement. So you'll see in the paper there is a commitment as part of this work to then review the other elements of the governance model. To ensure clarity of the purpose of the different elements of the governance in line with the developing of the collaborative strategy, but also to ensure that we minimise duplication and reduce the overall time commitment. So the next phase of this work will be to do that, and we'll again bring that back, hopefully in line with the presentation of the APC strategy in July.
Very good. We've discussed this pretty extensively. And Tony, any questions or comments that people want to make? In which case, can I ask for the board's approval for the creation of those standing committees, and we'll move on to the discussion of delegations. Excellent. Very good. Thank you. Keep going, Peter.
Thank you. As per in terms of delegated authorities, you remember last year we went through the same process around delegating authority from the four trust boards to the relevant committees to go through various year-end processes, and that includes obviously the annual report and accounts that we've talked about, the quality accounts, the self-certifications that we need to do, and also the review of standing orders and SFIs as appropriate to each individual trust. So we're asking for the four boards again to delegate that authority to audit committees and quality committees as appropriate to do that work on behalf of the four boards.
Everybody happy with that? Very good. Yeah, thank you, Peter. Good. So those are all taken through, and we are now on to the chief executives with anything you want to add that we've not covered so far. Tim, you're going to lead off with the EMB report.
Thanks, Matthew. The EMB report is the APC EMB report is there, I think, really for noting. I haven't got a huge amount to add. If the APC EMB is doing its job, then most of the stuff that we discuss will have come up in other agenda items here, because we would have been discussing the things that are of concern across the APC. And I think that we have, as you can see, so we had a very helpful deep dive into the mental health and how that works. We've talked about the EDI objectives for the APC, and as I say, we've talked about most of these things. I think that as we review the terms of reference for the collaborative committees, then I think obviously we just need to make sure that we use the APC EMB to make sure we've plugged all of the sort of executive gaps to make sure that the pathway of stuff from the executives in the individual trusts through to the collaborative and non-executive chaired committees are plugged. But I think it's a fairly self-evident report.
Thank you. Question, Nick.
I had a question. I suppose it's my audit chair's hat on in terms of the effectiveness of committees. I was just interested in terms of the rotation and how it's working, and do people feel it's effective having the way the rotation is working, and in terms of getting the breadth of views across the piece?
It's a good question, Nick. I think it's too early to say. I think we will probably review it after a full year and see. have some concerns about whether it will ultimately be effective, but I think it has been helpful, I think, to hear a range of views, and there is very definitely a range of views. So I think we need, I think, to give it a bit of chance to run. We're seeing the first sets of handovers from people as they've rotated, and so far there hasn't been a sort of sudden sense of going back to the beginning, which has been helpful. But I think we will formally assess that after a year's functioning.
Thank you. Okay, let's move on to the individual chief execs. Updates, and Pippa, anything you wanted to add?
No, I'll take the paper as read in the interest of time. Just 3 points. So staff survey, we were delighted with the progress actually. So 63 of the questions had improved, 33 remained the same, none of them had deteriorated. So recognise there's more to do, and we're absolutely ambitious in doing that, but very good progress we were happy with. Estates-wise, we've been handed over the 2 new theatres and the elective orthopaedic centre, so we're just doing our internal work to get them ready. We've also been handed over the ward, the new modular ward on top of ED, and we're doing our internal works to get them ready. And we took over the ownership of Wilston Eye Centre and opened that in month as well. So 3 great estates projects that have delivered on time, which is fantastic. We were delighted to win Trust of the Year at the GG2 Awards for the recognition of the work we've done on equality and diversity, which was fantastic and great to celebrate with staff. And just 3 shout outs to staff actually. First of all, Caribou, who won the Porter of the Year, which is great, and some great celebrations we've had with him. Taran Talia, who's one of our ENT consultants, who's been appointed as president of the ENT Society, which is fantastic. And I can't not mention Rose Nwanka, who is a nurse that's worked with us in our theatres at CMH for over 5 decades. She actually competed in the Olympics and was known as one of the fastest woman in Africa before she came over here to start a nursing career. So we've had a great send-off and celebration for her as well. She'll be greatly missed.
Brilliant. Thank you, Pippa. Leslie.
So thank you. So good staff survey. Pretty good operational performance, but needs to do better. I'm just talking to my own team here as I'm looking at them. But well done and thank you. And a final. So there were a number of call-outs here, but I just wanted to do this one, which was to Sandra de Oliveira Camillo, who you will have seen is one of our healthcare assistants who. Got the NHS Chief Nursing Officer and Chief Midwifery Officer Support Worker Excellence Award. I think that's pretty impressive. She deserves the board shout out actually. So well done her.
Very good. Thank you. Thank you, Leslie. Tim?
Thanks, Matthew. I think generally a couple of key highlights. Very pleased we were able to launch the Memory Support Concern service, which is the response to Martha's Law around deteriorating patients. I think that is a really helpful development. The Wembley Community Diagnostic Centre opened on the 1st of February. That is a really beautiful facility that's going to do 30,000 MRI and CT scans every year. I think that will be fantastic. Similar comments about the staff survey. Very pleased to have seen significant increase across a great many of the areas, which is good.
Tim, can you put your microphone on?
Oh, sorry.
Sorry.
And it was all such good stuff as well. Basically, everything's brilliant, and you don't need to worry about it. Martha's Law, call for concern, brilliant. Wembley CDC, brilliant. Staff survey, brilliant. ED performance in March, well over 76, and with a bit of jiggery pokery, we'll get over 80% because of the way that NHSE calculate our performance, which is very good news. I'm not going to look a gift horse in the mouth. Obviously pleasing that we've got confirmation about the CNST. And then a couple of things. Special commendation from the GLA on the Mayor of London's Design Lab project for our inclusive recruitment programmes. That was good to have that acknowledged. Very pleased that now well over 1,000 people have been involved in our engagement for equity and inclusion process, which has been fantastic. Delighted that Claire has started as Deputy Chief Executive, and we have Karen Powell and Ian Bateman as Deputy Coos, which is very good. And Merlin Marsden used to be the site director for Charing Cross, is now the Director of Services and Engagement for Private Care. Finally, can I commend to the committee, there are links in the research and innovation section if you're interested in a number of the, I think, really quite extraordinary projects that have been going on subsequently, and bits and bobs on the gate. And then in terms of recognising success, we are now a veteran aware trust. As you know, one of our trauma director is in charge of NHS England's Op Restore. So it's very good to get that recognition. We've received an NHS Pastoral Care Quality Award in recognition of the international recruitment and the high quality pastoral care to internationally educated nurses, which I think is great. We're able to, I think it's really good when you see apprenticeships, and we've got a lot of our apprentices done really well. Abiodun Fakoya won the Apprentice of the Year at our internal thing. She started as a housekeeper and is now has progressed into a role in human resources. And then we had two of our consultants have been made senior investigators by the NIHR, Alan Davis, who's our Director of Private Care, and Professor Graham Cook. So big congratulations to them.
Thank you, Tim. Thank you. And Patricia.
Last but not least. So again, I'm going to take the report as read. I just wanted to highlight, having specifically raised the issue around the CQC inspection of maternity, actually we had a very good IRMA inspection, which is an inspection of radiation protection, got a very good report on that, and in fact have very quickly had a report back saying that they're happy with all our actions, and that inspection report is now closed. Like everyone else, our staff survey results, actually we were really pleased. We increased the number of staff responding to the staff survey this year and saw a really significant upturn in a number of areas, and particularly pleasing, an upturn in the areas where we'd said we would prioritise and focus on actions to make a difference. So given that we started with quite a low base, it's been a really positive movement, and we intend to continue that this year. I want to say a massive thank you to operational and clinical staff. Actually, we set out the year, as everybody knows, we started the year as a National Oversight Framework 4 Trust. We moved to National Oversight Framework 3 last year by being able to show that particularly we had a strong focus on both finance and particularly on performance. And in fact, barring 2 patients, we made all of our performance targets that we needed to against the national standards. And like everyone else, achieved more than 76% performance in the month of March, and in fact have maintained that through April so far, and in fact have improved our performance. So that's very encouraging. In terms of recognition and celebrating success, like others, we have a number of staff who've taken on prestigious positions. So Yasser Mohsen has been elected as chair of the Court of Examiners for the Royal College of Surgeons. That's a very good place to be. Like Tim, we were honoured with the Pastoral Care Award for our international nurses. And I think actually that is really important, that we have a large number of international nurses coming to join our organisations, and what we must be very careful about is that we welcome them and make sure we look after them well. Coming to the UK can often be a very strange and difficult place to come to, so I think it's good that we recognise that, and we look forward to welcoming a number of midwives in the next few months. We were really pleased that in the PLACE survey, so the patient-led assessment of care and environment, we achieved the highest patient food score and the 4th highest cleanliness score in the country, which given our estate is a really good place to be. And a huge thank you to Steve and his team for some really interesting work that they've done this year about using digital solutions to improve the way we deliver our estates and facilities functions. So we really do understand how we're using our porters. We've introduced electronic ordering of food, which now means that we can really look at whether or not we're delivering patient food to the right people at the right time. So a number of really good pieces of work underway which has supported this. And then For some, it may feel a little bit of, well, didn't you have it before? But we did introduce the Da Vinci robot to the Trust this year, and the teams have done some great work. It doesn't sound like very much when we say 25 cases, but it's 25 cases with a very new bit of kit. And I mean, that was several months ago, and we're now moving forward with using the robot to a greater extent. So that's all I wanted to say.
Thank you, Patricia. Splendid. Excellent. I will move us on now to the use of the Trust seal, which is not about the zoo.
No. The report's there for noting. It summarises the use of the Trust seal in sealing contracts, etc., over the last year for the four individual trusts.
That is for the board to note. And Jonathan, the health and safety annual report.
Thanks very much. I'm Jonathan Reid. I'm the Chief Finance Officer at London North West, and one of the four kind of executive leads for the health and safety. So this is the first iteration of a report that I think will evolve and improve. It has been steered by Dawn Clift, Director of Corporate Governance at London North West, and one of that team, and under the kind of drive from David Moss to try and get us to have a lot more visibility on health and safety at the board. And I think already we can see some potential benefits in terms of consistency of approach, consistency of reporting. So Matthew, the aim, and colleagues, the aim is not to make it more detailed every single time we see it, but to make it more informative and insightful. And at the moment, what we're doing is stock taking, understanding that we've got commonality of process, and provide a little bit of assurance about some of the key issues that we're facing around the health and safety agenda. I hope that's helpful. Commend the report to the attention of the board.
Thank you. David, did you want to add something?
Yeah, thanks very much. So I think this is a classic example of the rear view mirror. And we've got three mirrors that are clearly quite clear. One's a bit foggy, but we've got three rear view mirrors. And I think we should look to move this discussion forward to a windscreen discussion. And it would be good to have a safety story at our next board meeting rather than a patient story or something a bit more generic. Because I think we've really got to get into leadership behaviour and a health and safety culture for what is the most important thing we do, and that is to look after the health and safety of our people, not just our patients. So obviously I'd encourage about the report because it's more than we've had before, but we've got to look forward a lot more and learn from others. Thank you.
Thank you, David. Any other comments? Excellent, in which case we note this report and your points about its ongoing development as a way of developing our approach to safety. Thank you. Very good. So, any other business? Nope. Really, in which case I will close the formal part of the meeting and open to questions from the public. So I have one posted in writing from Mike George Egan. If you would, Mike, do you want to talk us through your question?
Hello, can you hear me?
Yeah, yes, we can
hear you. Just to reiterate, item 11.2, Health and Safety Annual Report, and page 329 on the papers pack. Following on from the coloured pie chart, there's a table of summarised incidents broken down by trust. I'm intrigued that over the 22-23 period, Imperial noted 6 incidents of aggression or violence, whereas the other trusts noted none. I would say this would be statistically significant and might give rise to all sorts of wild speculation as to why Imperial would have more than their fair share of hospital thugs. Is any analysis proposed to suggest why this statistic and how to make hospitals safer for staff and patients? I have to admit, this was done by a very quick perusal of all those papers, and I could have more questions if you asked me.
I'm sure you could. Thank you very much. Tim, did you want to talk about that?
Yes, I don't think that the RIDDOR number of aggression incidents probably is the thing that makes me most concerned. I am, however, very concerned about violence and aggression in general in terms of the circumstances in which our staff find themselves working. And it is a constant concern to me. We have a group at Imperial that specifically looks at the actions that we can take to try and reduce incidents of violence and aggression. Indeed, I have just started to chair that group because I am sufficiently concerned about it as an issue for us to try and really get on top of it. And I think the issues are, I think, actually really quite complex. You know, I think there is definitely something about being clear about expectations around behaviour from everybody, but there is also a big thing about, you know, we are in our emergency pathways dealing with people who are often not able to behave in an entirely rational way, either because of their underlying illness or because of various substances they may or may not have taken. I think we are also operating in a situation where all of these services are under stress because of large numbers of people using them, and so both staff and patients are stressed, and that sort of creates a sort of pressure cooker situation. So I think there is a lot of work we need to do around being clear about expectations, being clear about how we expect staff to de-escalate situations when patients are violent, making sure they've got the training to do that, making sure that we've got an appropriate number of security staff in our, particularly our emergency departments, but also in places like major trauma wards. And one of the issues we may have in terms of RIDDOR is, of course, all of the major trauma come to St Mary's, and a lot of those are people who have, tried to do harm to themselves. So there are sort of multiple causes. So I think the summary is, yes, I am concerned about violence and aggression. I'm not sure that I would read into this that it's much, much, much worse at Imperial, but I think all trusts you'll find are putting in place actions to try and mitigate what our staff are reporting as increasingly difficult circumstances in which to work.
Thanks, Tim. Jonathan.
Thank you very much, Mike. And it's a tiny supplementary to Tim. I think Tim, of course, has described it perfectly, but Mike, I know you like to know about the data. I think there's a slight classification issue. So this is a subset, as I'm sure you've picked up, of the totality of violence and aggression or physical assault incidents across our 4 trusts, and this is regulatory reportable RIDDOR ones. So if you look in Chelsea and Westminster and London North West, you'll see reported incidents for physical assault or injury, which I think would be along the same lines as colleagues from Imperial have reported. And although it's not in the pack, the Hillingdon have reported that there are 2 RIDDOR related incidents. So Mike, one of the lessons, this is one of the joys of having colleagues commenting on papers, is we're going to take away and look at reporting consistency across the 4 trusts for that small subsection. It is really important regulatory reporting information. I hope that doesn't diminish from the key messages that Tim was giving, which is all about the importance of addressing the acts of violence and aggression against our staff.
Thank you for that, Jonathan. That's helpful. And I think we should just, in addition to that, these are very specific type of reportable incidents. If we go to our staff survey, we see actually the picture of how much abuse and aggression our staff are facing on a day-to-day basis, and that is a significant issue for us in terms of protecting our staff and allowing them to do their good work in conditions that are appropriate for that. And those numbers run to very large numbers of what people are facing every day. So thank you. Robin, you have a question.
Thank you, Chair. First of all, congratulations on covering so much ground in timely fashion and getting back to your timetable. My question relates to St Mary's, and I wondered if we could have an update on the rebuild of this great hospital, which has been in the new build programme and out of it, and I think some of us are not clear where it is at the moment, but we look forward to hearing about progress. Thank you.
Now I really won't be able to hold Tim back, so off you go.
Yeah. Thanks, Robbie. So We are technically in the new hospitals programme. We were just slid out of the 40. I think 40 is, yeah, anyway. The 40 that are due to be completed before 2030. As you know, we've been working very hard to try and accelerate progress on the Mary's site because we are so concerned about its general status and have been trying to speak to literally anybody who will listen to us. And unfortunately, you're now in that category. We have actually made quite good progress. We have basically, I think, been working hard with them to say, look, a no regrets move here is to try and get to a situation where we have designed the hospital and we've got planning permission. Because if we get there, then there are mechanisms where we could leverage the value of the land at St Mary's to start building until the new hospital's money comes through in 2030-31. And of course, if there's slippage from the rest of the new hospitals programme, there may be money that we could try and appropriate from the new hospitals programme. And they've been sympathetic to that. We are hoping to get a decision on whether they'll give us the first tranche of money to allow us to progress that work by the end of this month. So when we come back in July, I'm hoping, and I have said this, I have to say I have assured my non-executive colleagues on multiple occasions that the decision was just round the corner. But on this occasion, I really hope it is just round the corner. And when we come back in July, I will be able to give you a more positive still answer to that question.
So we've now moved from assurance to hope, which is splendid.
Could you just be clear who they is?
Sorry, yes. So they is the investment committee at the new hospitals programme that it gives out the money basically.
Which is part of the Department of Health.
Oh, and NHSE actually now.
Is it? And NHSE.
It's run.
Right. Thank you. Jim Greeley, question. Oh, sorry. Let me come to you. I didn't see you there. We'll come to you, Mr. Abfati. Jim.
Yeah. Hello. Thank you, Chair, for calling me. Really, I did not concert my question with Robin, but it's in the same vein. Listening to what Tim Orchard just said, I'd like to ask about Charing Cross and Hammersmith Hospital refurbishment, because I gather something will come through this month also about monies available. My question is this: if money does not come through, what will Imperial do? And I speak as somebody who's been treated successfully at Charing Cross and very much admire the hospital. And if money does come through, is there a kind of timescale where you expect work to be finished? And I was going to ask, moving on from that, is that in St Mary's replanning, there's been admirable work with local communities. Is a similar exercise planned for Charing Cross and for Hammersmith Hospital?
Tim, you're up.
Thanks, Jim. Lots of good questions, as always. So to start with your last question, yes, absolutely. We will have exactly the same process of engagement with our local communities to make sure that we redevelop the hospitals that are needed for the communities that we serve. I think that's really important. I think the situation in terms of money is, so the reason we've been focusing on St Mary's, quite frankly, is because St Mary's is the most likely hospital to fall down. And so the good news is I don't think Charing Cross is about to fall down. I think that what we will see is potentially the opportunity to do a much more sequential redevelopment of Charing Cross and Hammersmith, because Hammersmith there is a degree of flexibility about the site. There's one site, one called J Block at the front, you'll see it on the front right hand side, which is empty, and we can build on that, and then that can help to manage a decant strategy across the site. For Charing Cross, then it is possible, and I really wish I had never used this wretched phrase, to have a floor-by-floor refurbishment. And I coined that phrase many years ago, but it does summarise what we want to do. It has, unfortunately, been misappropriated by a number of people. At the moment, we have not done any of that redevelopment work. and we've not had money from the New Hospitals Programme to do that work. If we were given the money, then obviously we would do that, and we would also probably redesign the site, because as you know, the ground floor of the site is a complete maze. So there's quite a lot we can do. It will probably be, though, sequential, and it will probably take of the order of 10 years, I would think, from start to finish, because we won't do the sort of big bang rebuild that we have to do at St Mary's because of the constrained site. So I think that probably just about covered your issues.
I have a number more hands. I'm going to try and take 3 more questions. I'd ask people to be concise with their questions and their answers. Mr. Abdul Fatih.
Thank you very much. You mentioned EDI plans and measures you will adapt in order to improve, but I don't know, the trust may be different, but some do better, maybe. But what I know is a long way to go in that section. But the question I want to ask is exactly related to this, and people kind of respect us, not the power we have or the prestige, but how we treat with people less able than us. Since that's to the German, since you're in charge of the board, and given the fact that I asked your question about the disability representation on the board, what have you done so far? And that was a year ago. And all disabled people do not deserve to be represented on the board.
Lacey, did you want to come in on this?
I would like to ask you. Okay, sorry. I'll also ask you.
Well, Lacey, please.
Yeah. So I mean, we've had this discussion actually, and I'm absolutely with you. So when we're talking about the EDI agenda, we can't just be talking about race. We have to be talking about all of the characteristics. And I think one of the things we've talked about before is how you involve both people with physical disability, but also, and it's one of the things we have been talking about, is how we actually both provide care and involve people with learning disability in our trusts as well. And we've been doing quite a lot of work around that. So I think you're right. That we do need to be inclusive at all things. And the final thing I'd say, and I don't say this in a way to be sanctimonious, not all disabilities are visible. So that's the other thing that we need to be thinking about is, are there people who have disabilities that sit around at this table and all of our tables that have disability that we are either not declaring or we're not talking about? But I think the question is absolutely the right one, and we should find ways actually of being able to express our commitment to all of those characteristics in a way possibly we didn't quite do today because we've concentrated in one area.
Yeah, but to answer your specific questions now that you raised very...
Yes, I think one of the...
Sorry, may I answer 1 moment? Yeah. You did ask a while ago a specific question about physical disability represented on the board of an acute trust, and the good news is we do have physical disability represented on the board of these trusts. But thank you for having raised it. Is this a second question? Because I would like to move on to someone else.
I think I'll have to find another way. Thank you. Anyway, many moons ago, I asked a question relating to why the Imperial NHS Trust cannot have a diagnostic center, and one of the answers that I was given at the time was that once the ICS is formed, then we